నెక్స్ట్ ప్రోగ్రామ్ బాగుంటది.
నెక్స్ట్ ఇది కొంచెం మోర్ ప్రాక్టికల్ గా ఉండేటట్లుంది.
న్యూరో రేడియాలజీ నిహాల్ అండ్ డాక్టర్ మూర్తి ఫ్రమ్ గాంధీ మెడికల్ కాలేజ్, రిటైర్డ్ ప్రొఫెసర్. చెస్ట్, సిటీ చెస్ట్ అండ్ ఎంఆర్ఐ.
Ready to start?
Yes, sir. Just give me a minute. I'll just set it up. Yeah. Good afternoon, everyone, and welcome to the post-lunch session of the Allergy CME. We've had wonderful pre-lunch session with excellent talks, and now we move to the post-lunch session. And I now request Dr. Yashwant Rao, past Secretary of PATS and Executive Board Member of Central IAP from Telangana State. We are awaiting the presence of Dr. Narahari. I can't find him in the participants. If Dr. Narahari, you couldn't take the call. If you're around, please raise your hand. I'll unmute you. I'll hand it over to Dr. Yashwant to introduce the speakers for the next session and take things forward. Over to Dr. Yashwant.
Maybe in OP. Narar sir may be in OP.
Yashwant sir, you can begin, sir. I'll see if Narahari sir can join for the next one. Go ahead.
So good afternoon, everybody, and we welcome all you to the session on Allergy CME by Deccan College of Medical Sciences, PATS and IAP TCB. We have post-lunch session with very interesting topics by Dr. Jakka Srinivas, who is a consultant at Ankura Children's Hospital. He has his advanced training at UK after having completed a post-graduation, and his areas of interest are respiratory medicine, allergy. We have today Dr. Jakka Srinivas speaking on anaphylaxis, which is a topic of prime importance during this COVID era, during our vaccination, and he'll be discussing anaphylaxis due to various causes. So over to Dr. Jakka Srinivas.
So can you hear me? Can you hear me, sir?
Yeah. You're audible and visible.
Yes, Dr. Srinivas, please go ahead.
Okay. Yeah. So
go ahead,
everyone. Welcome to the post-lunch session. To begin with, I would like to thank the IAP for giving me this opportunity. So what are we going to discuss today? We're going to discuss the pathogenesis of anaphylaxis. What are the common triggers? What are the clinical features? The diagnostic criteria, the differential diagnosis, how we investigate and manage a patient with anaphylaxis. Most of what I'm going to talk about is the anaphylaxis guidelines from the World Allergy Organization. The latest ones are from 2020. There are some changes from the previous guidelines in 2011. So So I'll try to highlight some of the recent changes in the guidelines as well. So let's start with the case report. I saw this child a few years ago, a 9-month-old male child. He was training at a outdoor swimming pool in Gopichand Academy. Luckily, father was there at that time, and he was noted that the child was bitten by a yellow color insect. And within 30 minutes, the child developed swelling of the face. This was followed by a choking sensation in the throat and breathing difficulty. The child was rushed to a nearby pediatrician who gave injection hydrocortisone Neville and referred the child to us. So now, I'm open to all of you to think, what is the diagnosis of this child, and would you manage anything different in this child? So if you look at the definition of anaphylaxis, it's the World Allergy Organization has defined it as a serious systemic reaction that's rapid in onset and has a potential to cause severe problems, including death. So let's first discuss about the pathogenesis of anaphylaxis. The anaphylaxis can be immunogenic or non-immunogenic. If you look at immunological, it can be again IgE mediated or non-IgE mediated reactions. If you look at IgE mediated reactions, which is the classical anaphylactic reactions, whenever your body is exposed to an allergen, the B cells start making immunoglobulins, IgE. These immunoglobulins go and attach to the surface of mast cells. And following subsequent exposure, cross-linking of the immunoglobulins occurs and a lot of precursors are released that cause severe allergic reactions or anaphylaxis. Non-IgE mediated anaphylaxis can be through complement factors, particularly factors C3A, C5A, or it can be IgG mediated as well. Non-immunological can be due to direct mast cell activation, as can occur with certain drugs and other agents. And finally, there is idiopathic. So coming to the triggers, if you look at the IgE dependent mechanisms, the commonest triggers are the foods and followed by medications and then insect stings. IgE independent or non-IgE mediated can be seen with drugs, while including the radio contrast media, NSAIDs, and biological agents. And again, as we discussed, direct mast cell activation can be due to physical factors like exercise, alcohol, and medications, and idiopathic, where we can't find an apparent trigger. So the three commonest triggers are the foods, medication, and insect bites. If you look at the foods, the common foods which cause allergy all over the world are milk, egg, nuts, seafoods. In addition, foods specific to different localities like celery, peach, sesame, buckwheat, and in Asian countries, chickpea, rice, etc. can cause anaphylaxis. And one interesting cause of anaphylaxis in Singapore is bird nest soups. So the foods that trigger anaphylaxis are local to the region. So we should be familiar with the common foods taken in the area as well. If you look at the medications, any medicine can potentially cause anaphylaxis, but the commonest ones are antimicrobials, the common antibiotics which you use, the penicillins, the cephalosporins, the NSAIDs, radio contrast medications, drugs which we use in theaters like neuromuscular blocking agents, sedatives, hypnotics, chemotherapeutic agents, biological agents, contaminants in medicine, latex which you use in gloves and other medical instruments, and iatrogenic causes like allergy testing, particularly intradermal skin test has a greater risk compared to percutaneous testing, allergy challenges, and immunotherapy. If you look at insects, again, they are specific to different locations, but the common insects which are incriminated are bees, honeybees, which is the first one. Is the honeybees. Then you can have wasps, fire ants, and horseflies in different parts of the world. So if you look at across the world, these are the common triggers for anaphylaxis, and we discuss most of them. Then when do you call it idiopathic? So when we take a very detailed history, we do all allergy tests available, can be either skin prick test or specific IgE, and we are unable to find any potential trigger, then we call idiopathic anaphylaxis. But even in this case, there could be a novel allergen which we may not be aware of. For example, this morning Dr. Nagaraj sir has discussed some potential new allergens which can cause anaphylaxis, which we may not be aware of. However, in these children, we need to rule out any underlying mass and disorders as well. So coming to clinical features, what are the clinical features you can expect in a child with anaphylaxis? So let's first look at the systems involved. The skin and mucosa are the most common systems involved, followed by the respiratory tract, the GIT, cardiovascular system, and lastly, if not the least, the central nervous system. So if you look at the skin, there can be flushing, rashes, itching, urticaria, and angioedema. This can involve the periorbital region, conjunctiva, the face, including the lips, tongue, palate, and external auditory canals. It can involve the genitalia, palms, and soles as well. If you look at the respiratory symptoms, they can be broadly divided into upper and lower airways. The upper airways can cause nasal itching, congestion, rhinorrhea, and sneezing. It can be throat itching or tightness, but important are hoarseness, stridor, a choking sensation, dysphonia, etc. These are the important and severe symptoms. If you look at the lower airways, there can be cough and signs of respiratory distress, but there can be wheezing, decreased peak expiratory flow, cyanosis, and respiratory arrest. So these are the severe symptoms. If you look at the cardiac symptoms, there can be chest pain, palpitations, there can be problems with the cardiac rhythm, hypotension, syncope feeling. There can be after effects like urinary or fecal incontinence, which finally leading to shock and cardiac arrest. It's interesting to know that there is a very short time from the exposure to the allergen to the cardiorespiratory arrest. It can be as less as 5 minutes in iatrogenic causes, 15 minutes following insect stings, and 30 minutes in food-induced anaphylaxis. So we have very little time to act from the start of the symptoms. So when do you call it hypotension? In infants and children, any systolic blood pressure lesser than the level expected for the age, or if you already know a baseline, a greater than 30% decrease in systolic blood pressure is taken as hypotension. In adults, anything less than 90 or 30% decrease from the patient's baseline. So we all know this formula for calculating the blood pressure for different ages. So if you look at the GIT symptoms, it's persistent or crampy abdomen pain, nausea, vomiting, diarrhea, dysphagia. These are the symptoms. GIT symptoms can be seen in milder allergic reactions as well, but what is important in anaphylaxis are the symptoms have to be severe or persistent to consider the diagnosis. Look at the neurological symptoms. One of the classical symptoms of anaphylaxis is an aura of impending doom. So the patient knows that there is something bad going to happen. He's not easy, he's uneasy. There can be change in behavior. There can be a throbbing headache. There can be altered mental status ranging from dizziness to confusion, and there can be visual problems as well. So do the patient need to have all of these symptoms to diagnose anaphylaxis? Definitely not. So there comes the new modified diagnostic criteria where anaphylaxis is likely when one of the two criteria are fulfilled. So there is an acute onset within minutes to hours of exposure to an allergen with involvement of skin and mucosa or both, and at least one of the following. That can be either respiratory compromise or cardiovascular compromise or severe GIT symptoms. So you have skin and mucosal involvement plus involvement of one of the systems, one of the three systems. That's one criteria. The second criteria is acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known allergen for the patient, even in the absence of typical skin involvement. In other words, there need not be skin or mucosal involvement, but in a child, in a person with known allergies, if there is a respiratory or cardiovascular compromise following an exposure to known allergen, that itself can be diagnostic. So to simplify, criteria 1 is typical skin symptoms and significant symptoms for at least one other organ, or in a patient with a known or probable allergen with only respiratory or cardiovascular compromise. It's not only the allergen, it's also some patient risk factors that decide the severity of the reaction. These can be age-related factors. For example, it can be worse in infants and elderly, adolescent and young adults because of the risk-taking behavior, pregnancy. It can be due to concomitant diseases, particularly asthma, allergic rhinitis or eczema, cardiovascular disorders, patients on certain drugs like beta blockers or ACE inhibitors, or patients with underlying mastocytosis or mast cell disorders. Concurrent medications, as we already discussed, beta blockers or ACE inhibitors, those taking alcohol, sedatives or hypnotics, antidepressants or recreational drugs. And the cofactors that amplify anaphylaxis can be exercise, infection, stress, disruption of routine, and premenstrual status. So these are all the patient risk factors that can exaggerate an anaphylactic reaction. So then coming to differential diagnosis. If you look at the respiratory symptoms, it can be anaphylaxis can be mimicked by severe asthma, anxiety or panic attacks, foreign body aspiration. The skin symptoms can be mimicked by urticaria with or without angioedema. The cardiovascular symptoms can be mimicked by syncope and shock, pulmonary embolism due to whatever cause. And the GIT symptoms can be mimicked by food poisoning and FPIES or food protein induced enterocolitis syndrome. So is there any role of any investigations? Before I discuss, I would like to say that anaphylaxis is a clinical diagnosis and the role of investigations is limited. However, for the sake of completion, I would like to mention two tests. One is tryptase. The sample should be obtained 15 minutes to 3 hours after the onset of symptoms, and serial samples are more useful and comparing with the baseline level. So very high baseline tryptase levels will suggest mast cell disorders. Levels elevated above baseline will confirm anaphylaxis. That's particularly seen after insect stings or medications and in patients who become hypotensive. However, a normal tryptase levels does not exclude anaphylaxis, especially in those reactions seen after food and in patients where the blood pressure is normal. There are other conditions where the tryptase can be elevated. For example, myocardial infarction, trauma, SIDS, etc. Coming to histamine, again, there are many precautions you have to take while taking the sampling. It has to be taken within 15 minutes to 1 hour. The sample has to be handled at particular temperature. And histamine and its metabolite has to be measured. And again, I would like to reiterate, anaphylaxis is a clinical diagnosis. So then comes the management of anaphylaxis. So let's come to a case. We had a 6-year-old child admitted with suspected sepsis. He was prescribed IV ceftriaxone. The child developed a rash within 5 minutes of the third dose. So the child was given antihistamine and continued. Child then developed swelling of the face followed by breathing difficulty. So what would you do in this case? So what is the first line drug in the management of anaphylaxis? Are they antihistamines, adrenaline, or corticosteroids? So how do we treat it? So these are the important steps in the management of anaphylaxis. First, all hospitals managing these children should have a treatment protocol. Second thing is remove the trigger. For example, if it is caused by an IV antibiotic, stop the antibiotic immediately. Do a rapid assessment like you do for a PALS ABC assessment. Call for help. Right posture. Place the patient in a supine posture with the legs elevated. And adrenaline should be given intramuscularly without any hesitation. Get a wide bore IV access. Give some oxygen. Resuscitate with fluids and whatever is required. And monitor the patient regularly. So how do we give adrenaline? What is the dose? And what is the preferred method of giving adrenaline? This is the most important slide I would like to take home. Adrenaline, the concentration is 1 in 1,000 given by intramuscular injection in the anterior lateral aspect of the thigh, 0.01 milligram per kg. So it has to be very clear. It's 1 in 1,000 concentration given intramuscularly at 0.01 milligram per kg. The dose can be repeated every 5 to 15 minutes if needed, and the rest of the resuscitation, like giving supplemental oxygen, fluids, etc., has to be done like any other case. Failure to administer adrenaline promptly will increase fatalities, including encephalopathy, and also increase the risk for biphasic response. And what is the dose? So if you don't know the weight of the child, what would you do? Infants under 10 kgs, the same dose, 0.01 milligram per kg. 1 to 5 years, you can safely give 0.15 milligrams. Above 5 years, 0.3 milligrams. Teenagers and adults, you can give 0.5 milligrams. The maximum is 0.5 milligrams. And even if you can't measure the dose exactly, what I would like to reiterate is giving an appropriate or approximate dose is more important than trying to find the correct dose. So the earlier to give the dose, the better the prognosis will be for the patient. So why should we give adrenaline only intramuscularly? The reason being, adrenaline has a vasodilator effect on smooth muscle, particularly the skeletal muscles of the thigh. And the skeletal muscles of the thigh have very good vascular supply. It is very well tolerated when given intramuscularly, and the absorption is rapid. If you give subcutaneously, it causes vasoconstriction that may delay the absorption of the drug. Oral is ineffective. IV adrenaline is indicated in intensive care settings for treatment of shock and cardiac arrest. How does adrenaline act? So there are three main types of receptors. The alpha-1 adrenergic receptor causes vasoconstriction, increases vascular resistance and blood pressure, and decreases edema in the airways. By means of the beta-1 adrenergic receptor, it increases the cardiac contraction and heart rate. And by the beta-2 receptors, it decreases the mediator release and increases bronchodilation. And what is the end effect? It decreases all the symptoms of anaphylaxis you can think of, including urticaria, angioedema, laryngeal edema, wheezing, hypotension, and shock. So it's a complete drug for all the outcomes in anaphylaxis. Like any other medicine, it can have its side effects: pallor, tremor, headache, anxiety, palpitations, dizziness, etc. Overdose can cause arrhythmias, hypertension, and pulmonary edema. So coming to other medicines, what is the role of antihistamines? They usually help in skin and mucosal symptoms like itching, flushing, urticaria, upper respiratory symptoms like sneezing and rhinorrhea. However, they are not a substitute for adrenaline, and they're very in a slow acting relative to adrenaline. And the Cochrane review has shown no efficacy as a first-line treatment for anaphylaxis because they do not prevent or relieve obstruction to airflow, and they do not treat the cardiovascular compromise. What about beta-2 agonists like salbutamol? They can reduce wheeze, cough, and shortness of breath, but again, they are not substitute for adrenaline. They do not relieve upper airway obstruction, and they do not treat the cardiovascular problems. Corticosteroids, again, one of a drug which is used more frequently than adrenaline, unfortunately. The onset takes several hours. They're not life-saving. They have some possible role to prevent protracted or biphasic anaphylaxis, but again, that's controversial. And the Cochrane review found no evidence for any effectiveness in the anaphylactic reactions. So what do we do with refractory anaphylaxis? It should be managed in a ICU setting by experienced personnel because the intubation will be extremely difficult. They may require IV vasopressors. They may require glucagon, particularly those patients on beta blockers and other medications as well. So what do we do? Manage protracted. Further management consists of management of any protracted anaphylaxis in that case. Watch for biphasic anaphylaxis, which means that once the child recovers, there may be again release of the chemical mediators and there can be recurrence of symptoms. This can be seen 4 hours to up to 72 hours after the initial attack. So we have to monitor carefully for that. Education of the family with regard to recognition of symptoms, giving them an anaphylaxis management plan, and teaching them how to give adrenaline at home and follow up. So when they come to follow up, what is the long-term management? Long-term management consists of identification of the trigger. This can be by their skin prick test or specific IgE. Making sure that the family have an anaphylaxis management plan, educating them, making sure they have adrenaline injections at home, management of potential risk factors, particularly asthma, because we know that the risk of anaphylaxis increases in children with poorly controlled asthma, prevention of recurrences by preventing exposure to the potential triggers, public health measures like making sure that the food labeling is done properly to prevent food-induced anaphylaxis, and follow up child every year to make sure that they're doing well and they have adrenaline in place. So adrenal auto-injector, I mean, these are available abroad and hopefully they'll be available soon for us. They're available in 3 doses. They're pre-filled adrenaline injections, 0.1, 0.3, 0.5 milligrams. So there is, how do we give that? You pull off the safety release, hold it close to the thigh and press it, and then the needle penetrates and it holds for 3 to 5 seconds. However, when we don't have that, there are alternative methods. You can give the family an ambulance syringe and teach them how to use it at home, or you can give them a pre-filled syringes. But remember that adrenaline is sensitive to light, so it has to be stored safely, and do not store above 25 degrees and do not freeze. So these are some things to remember. So I haven't touched food dependent exercise induced anaphylaxis because Nagaraj sir has covered it in the morning. So the points to remember are: anaphylaxis is the most severe form of acute systemic allergic reaction. However, it remains poorly recognized due to lack of awareness, partially due to the wide clinical spectrum it can present with. Always remember, adrenaline 0.01 milligram per kg of 1 in 1000 by intramuscular route into the thigh is the treatment of choice, because delay in treatment can lead to fatalities. And at follow-up, we need to identify the triggers and give the family a management plan. Thank you.
Srinivas, you stuck to the time and your presentation is very clear. When to use steroids, what is the role of antihistamine, and it is better to use intramuscular rather than subcutaneous. And the last slide, the points to remember is very crystal clear. And your there is a question on in the chat box. Anaphylaxis by insect bite. What is the mode of treatment?
Okay, what is?
Does it differ from the normal anaphylaxis? By Dheeraj Mohan Gupta.
The treatment.
And next one, up to what age anterior lateral part of the thigh can be chosen for giving?
Okay, sir. Answering the first question, insect bite, the treatment is the same as in any other anaphylaxis. The only thing would be if you are able to identify the insects, in some cases there may be potential for immunotherapy. If the patient cannot avoid exposure, say for some occupations are exposed to insects so in that case immunotherapy can be considered, but the initial acute management is the same irrespective of the cause. And the next question, across all ages, the preferred site is anterolateral aspect of the thigh, the vastus lateralis. That's the preferred site.
Thank you, Srinivas, for your lucid and clear presentation. Thank you so much.
Thank you, sir.
If there are any questions, kindly post in the chat box. Dr. Srinivas will be answering you.
Sure, sir. Definitely. Thank you.
How many cases have you seen with fish being taken as presenting as anaphylaxis in your practice?
Sorry, sir. How many
fish
cases?
As a cause of allergy or?
Fish and seafood, they are usually more in adults, sir. In children, the common causes are milk, egg, wheat. These are the ones. And as the age increases, then the nuts and seafood, they are the more common in adults.
Thank you, Srinivas.
Thank you, sir.
We have a next talk on urticaria by Dr. Surendranath. Dr. Surendranath is the president of PATS, and he has been the Central IAP EV member twice in 14 and 16. He is the past secretary of IAP, the FBS IAP. His areas of interest are allergy. He is a trained allergist at Savita University, Chennai, along with our dynamic secretary Pavan. under Dr. Major Nagaraj. So he'll be talking on urticaria, the most important topic. Over to Dr. Surendranath.
Yeah, thank you, Yashwant. Is it clear? My voice is clear? Is it clear or any disturbance is there? My fan is running. Yashwant.
It's clear, sir.
Okay, thank you. Thank you, Yashwant. And thank Srinivas Jakka for giving 2 minutes extra to me, because there are too many slides are there. Urticaria is a very large topic. And at the outset, I thank Deccan Medical College for taking up a very important CME along with the Indian Academy of Pediatrics, Telangana State and TCB branch. Thank you very much. Thank you, Narayan Reddy and Ashfaq Hassan, taking initiative for this wonderful CME. The urticaria is the most commonest manifestation which we see in the clinics. I think most of us have seen this type of manifestation many times in our clinic. Children are brought with wheals and severe itching will be there. This type of presentation is very common post infections. Mostly it is followed by upper respiratory infection or viral infection. These type of rashes do get in our OPD. By definition, urticaria is a vascular reaction of the skin marked by appearance of a smooth, slightly elevated patches that are erythematous, often associated with severe pruritus, usually resolves within 24 hours, which is caused by the degranulation of histamine containing, that is mast cells, into the superficial dermis. Most of the time, urticaria, whatever reaction occurs is in the superficial layers of the dermis. Whereas coming to the angioedema, angioedema is the extreme part of urticaria. It is a condition in which swelling of the deeper tissue involving the smaller blood vessels also you can see. And mostly angioedema occurs in the wherever loose tissue is there, like lids, tongues, hands, feet, and genitalia. And sometimes laryngeal mucosa, gastrointestinal mucosa can also get involved with angioedema. Sometimes urticaria, angioedema can present together. Sometimes only angioedema may be present. So this is the type of the wheal which occurs with the urticaria, where raised edges are seen, whereas the angioedema, usually you will not see raised edges. It is a uniform swelling of the tissue will be there, mostly involving the deeper tissue of the skin. So when you have an angioedema of the larynx, you can see laryngeal edema will be there, as Dr. Srinivas Jakka has told that anaphylaxis because of the bee sting or any other thing, laryngeal edema may be there, choking the patient, which requires an immediate treatment. This is CDC report which shows that even in America, well-established medical care is there. There also you see about 50 to 80 deaths because of the bee sting, anaphylaxis or laryngeal edema. So coming to this is another type of urticaria. This is not an urticaria with vasculitis. Whenever there is vasculitis is there, usually the disappearance of urticarial rash will not occur before 24 hours. If the urticarial rash prolongs beyond 24 hours, you should think of urticarial vasculitis. And at the same time, apart from itching, there may be burning sensation as far as urticarial vasculitis is concerned. And now it is a COVID era. You can see the COVID era. What happens is we see a lot of cases of COVID even in the children. These are some of the cases are presented with COVID with the urticarial lesions. This one case which was reported, there are some case reports in the international journals. This girl is 2 months old, brought to the emergency department due to the urticarial rash, fever of 4 days duration, rash localized to the face and upper extremities initially, which spread to the lower extremities, and palms and soles are not affected. And there is no angioedema of the tongue or fingers. Parents were COVID positive, and there is a interest, and the child was also COVID positive. So in the present scenario, we are supposed to see such things which can come as urticarial rash for the COVID also. Whenever there is somebody having fever with urticarial rash in the present scenario, think of COVID also. So coming to the pathophysiology, urticaria is basically a mast cell driven, and also basophils are involved. As I have told you, it is an aberrant release of histamine from the activated mast cells and other inflammatory mediators such as leukotriene C and D, platelet activating factor, prostaglandin D2, and components of complement and coagulation cascades. These are the factors which are responsible for the reaction which occurs in the skin. These mediators stimulate sensory nerves and elicit vasodilatation and plasma extravasation. As far as the pathophysiology is concerned, it can be a IgE mediated one, or sometimes it can be a non-IgE mediated. Non-IgE mediated urticaria usually caused by the radio contrast agents and Epstein-Barr virus and hepatitis B. As the four mechanisms which are involved with the hypersensitivity, one is the type 1 reaction, type 2 reaction, type 3, type 4. All the four types can occur and cause urticaria, in fact. So, explaining how it happens is already Srinivas has told that how the histamines and chemotactic factors are released, and the mast cell which is already coated with IgG2 particles of the IgG on the mast cell, then an antigen comes in contact with these things, then the reaction will start and the leukotrienes and degranulation will come, histamines, cytokines, chemokines will be released and urticaria occurs. So the central role is played by the mast cells. These mast cells can be degranulated by allergens, autoantibodies, and complement deficiencies also can occur, causing angioedema. So this leads to the mast cell degranulation and stimulation of neuroimmune interactions. Immune cells and activation and recruitment will be there with eosinophils and basophils. And sometimes it can cause vasodilatation, vascular permeability. So the basic culprit as far as urticaria and angioedema is concerned, it is the mast cell, and degranulation of the mast cell is the reason for the urticaria. So pathophysiology, the stimulating factors for the mast cell can be non-immunological, like chemical histamine liberators, opiates, polymyxin, antibiotics, and thiamine, or physical agents like cold, heat, and sunlight, and immunological factors, alternative complement pathways, or type 1, type 2, as I told you, some of them may be IgE mediated, and some of the genetic factors. So all these factors can lead to the degranulation of the mast cells, can cause urticaria. So incidence, we all know that we see a lot of cases. It affects of 20 to 25 population at some time of their life. The prevalence is reported as 2% to 6.7% in children and adolescents. In India, almost prevalence of urticaria has been found to be 2.5% in children below 14 years. And the lifetime prevalence of urticaria reported is 7.8 to 22.3 with a point prevalence about 0.5 to 1% in adults. If you classify the urticaria, you can classify into a spontaneous urticaria and inducible urticaria. The spontaneous urticaria can be acute spontaneous urticaria, chronic urticaria. In inducible urticaria, maybe a physical or an autoimmune. So if you come to that division, urticaria, as I told you, the wheals appear less than 24 hours is acute urticaria, and the urticaria duration of less than 6 weeks is known as acute urticaria. Whenever wheals do not disappear within 24 hours, it is urticarial vasculitis. And whenever the urticaria is prolonged more than 6 weeks, then it is known as a chronic urticaria. So the duration of the urticaria is very important. Less than 6 weeks is acute urticaria. More than 6 weeks is chronic urticaria. Then chronic urticaria can be a spontaneous one or an inducible one. Inducible urticaria can occur with the physical things like dermographism, delayed pressure, cold urticaria, heat urticaria, or sometimes solar exposure and vibratory urticaria may be there. Non-physical, contact urticaria, cholinergic urticaria, aquatic urticaria, exercise use. These are the causes of chronic inducible urticaria. Whereas urticaria can occur spontaneously. In such situations, it may be because of autoimmune, sometimes chronic infections and food additive can be one commonest cause of chronic spontaneous urticaria. Sometimes you may not find any cause for the urticaria. So this is the classification of the urticaria is concerned. In one of the study which is published recently in 2020 from PGH Chandigarh shows that this is the incidence of urticaria in the children. In fact, it is a chronic urticaria. What are the causes of chronic urticaria? If you see, the chronic spontaneous urticaria is the most commonest chronic urticaria. apart from chronic dermographic urticaria and cholinergic urticaria to some extent. The rest of things are very minimal. So even in children also, it shows that chronic spontaneous urticaria is more common. So etiology, you can divide them. Lot of agents can cause urticaria: food, medication, insect stings, infections with the bacteria, infestation with the parasites, fungal infections, and sometimes contact allergens like latex, pollen, animal saliva, and transfusion reactions because of blood, IgG. These are all the various causes of acute urticaria. When you come to the chronic urticaria, as I told you, physical urticaria is because of exposure to these or dermographism, cholinergic. When you are exposed to sometimes cold, you can get urticaria, heat-induced urticaria, delayed pressure, solar exercise, vibration, etc. These are the physical causes of chronic urticaria. For other causes of chronic urticaria, you can have rheumatological causes like SLE, JRA, mixed connective disorders, endocrine causes like hypothyroidism, hyperthyroidism. Sometimes malignancies also can cause urticaria. Vasculitis, arterial vasculitis, as I told you. Environmental causes can be some of the allergens like pollen and animal cancer. Infections, herpes virus, hepatitis, Helicobacter pylori is also supposed to cause chronic urticaria. Parasite, Giardia, Ascaria. So these are the various numerous causes of urticaria there. If you see 75 to 90% of chronic urticaria, it is mostly idiopathic, where you don't find any cause actually. So this is commonest cause of pressure urticaria, in fact, you can see. And these are the urticarial rashes because of the cold exposure. Either cold can be air currents, cool air currents, or the sometimes liquid, cool liquid, or solids can cause this type of urticaria. And cholinergic urticaria, whenever you are exposed to the high temperature, whenever there is a lot of sweating is there, this type of urticaria will come. And this is dermographism, where any pressure can cause this type of urticaria. And coming to the urticarial activity score, this is important as far as the treatment aspect is concerned. When you start the treatment, you compare urticarial activity score with the urticarial activity score after the treatment. This consists of two things, pruritus and the wheals. And the scoring is 0, 1, 2, 3. And whenever pruritus, depending on the mild, moderate, intense pruritus, scoring is given. Wheals, if they are less than 20 in 24 hours, 20 to 50 is moderate, more than 50 is severe. So scoring is done. A sum of the 0 to 6 for each day is summarized over a week, and maximum score you can get is 0 to the maximum 42. This score is very important as far as the treatment effect is concerned, so that you can assess your treatment effect. Urticarial severity score is also there, but it is a very difficult thing. 12 questions are there and 7 responses for each question, and it is supposed to be more sensitive than dermatological life quality index. So angioedema scoring is also there. You can go through it. Lot of literature is there. Angioedema scoring, it is patient self-reported. There are 5 criteria for scoring: duration of the angioedema, physical discomfort, impact on daily activities, impact on appearance, and overall severity. So 0 to 3 points each one. Total score is 0 to 5. And this is also summarized weekly or 4 weeks or 12 weeks, so that you get a score of angioedema activity score. So coming to the diagnosis of urticaria, detailed history is essential, as all the allergic disorders require a detailed history, and there should be a physical examination, proper physical examination should be done, and proper investigations depending on the type of urticaria we have to do to come to the conclusion what is the cause of urticaria. But in spite of this, there may be a lot of times you may not find a specific cause for the urticaria. So history, you have to take what is the time of onset of the disease, and presence of any specific precipitating factors are there. Association with angioedema and anaphylaxis previously. This is also important as far as treatment is concerned. Persistence of individual wheals beyond 24 hours. That means it could be urticarial vasculitis or any other causes of vasculitis can cause. And the use of the drugs and the treatment history is very important, because some of the drugs can itself cause urticaria, and treatment history is important to change the modalities of the treatment. And how is the quality of the life? How is the whether any disturbance in the daytime or whether the sleep is disturbed, quality of life is very important. So these are the various investigations which have been published by the Dermatological Society in Indian Dermatology, Indian Journal of, and this is the consensus paper is there in 2018. In that they have mentioned these are the type of investigations which have to be done. As far as spontaneous acute urticaria is concerned, which is a self-limiting condition, so there is no need to do any tests. Whereas in chronic spontaneous urticaria, we have to do CBC, TSR, TSH, and other tests for autoantibody tests also you have supposed. Inducible urticaria, you can induce the urticaria with the use of certain physical measures. You can demonstrate that urticaria is coming. So the routine investigations, as I told you, CBC, TC, peripheral smear, ESR, urine for routine and culture, it has to be done. CRP, ASO titer, these are important things to rule out any investigation, infections. Why? Because the infections are the most commonest cause of urticaria in children. Any other infections, they can present with urticaria in children. So what are the tests we do for chronic inducible urticaria? As I told you, inducible urticaria is because of the physical and non-physical causes. The physical causes, one is the most commonest is delayed pressure urticaria. Whenever there is pressure over the skin, urticaria will come. The weight of 5 kg with 6.5 centimeter diameter kept on the skin for 15 minutes and we look for the urticaria. Then heat provocation test. A cylindrical glass or metal filled with warm water at 45 degrees is to be applied on the forearm for 5 minutes and look for the bead. Then ice cube test for the cold urticaria, you can put an ice cube in a plastic bag, apply to the skin for 5 minutes and look for the urticaria. Then temp test. Temp test is a device which is used to diagnose cold and heat urticaria between the temperatures of 4 degrees and 44 degrees. I will show you in the next slide, I will show you the photograph of the temp test where you can diagnose what is the temperature which is inducing the urticaria in a particular patient. And cholinergic urticaria, ask the patient to do exercise for 15 minutes. If positive patient subjected to the warm test by giving a bath at 42 degrees, till the core temperature rises by 1 degree centigrade, up to 15 minutes to rule out exercise induced urticaria. Solar urticaria provocation test is done by exposing small area of the skin to the UV light for 10 minutes, or sometimes you can use the light of LCD projector also to demonstrate solar urticaria. Vibratory urticaria can be induced by rubbing a towel across the back of the patient. This aquagenic urticaria, apply just a wet cloth for 20 minutes around the arm and you can look for the urticaria. A dermographism can be elicited reaction with a blunt, smooth objects or stroking with a dermographometer. This is known as Frick test. In fact, you can use a ballpoint pen without any inside. There should not be any ballpoint. Blunt ballpoint pen can be used for the Frick test. Patch test is filled with suspected antigen, is applied to the skin in an area observed for 30 minutes in an area of 24 hours. So this is the various tests which are available to induce urticaria with the physical things. As I told you, this is the instrument which is used for the Frick test. This is for the dermographism. You can demonstrate the dermographism with the different sizes of this blunt pointings will be there. With that, you will know how much urticaria will be developed with how much pressure is there. So this is a temp test. This is an instrument with varying degrees of temperature. The hand will be applied, then the urticaria develops at different degrees. Then you can see what is the temperature at what urticaria is induced. So coming to the chronic test in the chronic spontaneous urticaria. This is inducible urticaria test which we have seen. Spontaneous urticaria is mostly because of autoimmune causes. One of the most commonest autoimmune causes detected by using an autologous serum skin test where the patient may have antibodies against the IgG FCCR receptors. So what happens is, whenever they have IgG antibodies against IgG, the patient may develop urticaria. For those patients, you can take patient's own serum 50 microliters with saline as a negative control and histamine as a positive control. You can do like this. This is a skin prick test. Differences of 1.5 mm mean perpendicular diameter. Serum is considered as positive. So difference of 1.5 mm between the saline and the serum suggests that this patient is having an autoimmune urticaria. Thyroid function test, thyroid antibodies has to be done to rule out any hypothyroidism or hypothyroidism. Sometimes we may have to do anti-nuclear antibody if you are suspecting SLE, and skin biopsy when you are expecting vasculitis. And allergy tests also very important. Some of the food allergies or pollen sometimes cause urticaria. So skin prick test is very essential. It's specific allergy. And sometimes have food allergies. You can do a prick to prick skin test where one prick into the particular food or a fruit, then it is injected into the skin prick test, which will show in duration if there is allergy for a particular fruit or vegetable. So intradermal tests of IgE mediated drug allergy can be done in some of the drug allergies. And another is serum specific IgE testing can also be done if you know specifically what is causing the allergy. Some of the serum specific IgE testing can be done in this. So other tests are to rule out angioedema. Sometimes you may have to do, and hereditary angioedema can be detected by screening tests for C4, C1 esterase inhibitor levels, and evaluate the severity and activity of the disease. Sometimes you may have to do these tests, which are not very essential. And if you are suspecting any genetic problem like hereditary angioedema, then you can do genetic studies. So coming to the management of acute urticaria, as I told you, it is a milder form of anaphylaxis, definitely involving only the skin. So in that case, avoidance of allergen is very important, and it is a self-limiting problem. Only H2 second generation H1 antagonists are enough, like cetirizine, levocetirizine, fexofenadine. These things can be used in acute urticaria. And if it is very severe, whenever there is a lot of edema is there, maybe you can give. Severe cases, epinephrine can be given in the same dose, which Dr. Srinivas has already explained you. And sometimes you can give a short course of steroids. And for soothing effect, you can apply the calamine lotion. For a chronic urticaria management, it is very difficult for treating the chronic urticaria. Aim is early and complete symptom control should be there, because the itching is very severe. Patients will be in a lot of discomfort because of the itching. So we have to reduce the symptoms immediately, and complete symptom control should be there. So we have to remove the identifiable cause, avoidance of trigger factors, especially NSAIDs, minimize the stress and exposure to the heat, care of dry skin with moisturizing creams are important, calamine lotion for local application, and stepwise treatment should be increased according to the history and response to the treatment. So the first line of therapy in chronic spontaneous urticaria or a chronic urticaria. So number one is first generation antihistamine should not be used because they impair with the cognitive function of the child. So there will be a lot of drowsiness will be there. So first generation antihistamine should not be used as a first line of therapy. The second generation antihistamines like cetirizine, levocetirizine, loratadine, desloratadine, fexofenadine, bilastine can be used as the first line of therapy. Bilastine is recently introduced, which can be used after 6 years. It is not permitted to be used after 6 years. So doses can be increased up to 4 folds. If there is no response with the smaller doses, you can increase up to 4 folds. Before stepping up the dose, wait for at least 1 to 2 weeks after starting the treatment, and look for the response. Wait for 2 weeks, and you can increase the doses 4-fold. There absolutely will not be any problem. And there is always no need to give 2 antihistamines. Remember, only 1 antihistamine is enough. And no use of shifting from one antihistamine to the other antihistamine. Technically speaking, if one antihistamine is not working, the other antihistamine may not work. So you can increase the dose rather than switching over to the other antihistamine. You may switch over to the other antihistamine for commercial purpose, otherwise there is no use. So use of corticosteroids in chronic urticaria, there is lack of control studies, and it is not recommended for long-term use because of the side effects. Sometimes may be given for a short course, and when all the therapies have failed, or in a case of emergency, you can give this corticosteroids for a short course of 5 to 7 days. Tomalizumab is one of the beautiful molecule. Again, it is an anti-IgE and monoclonal antibody. In fact, we have lot of discussion regarding the omalizumab in the morning session. Asfaq Hassan has clearly told how the omalizumab acts in the allergic disorders. It in fact binds with IgG and then blocks the action of the IgE on the mast cell. So humanized monoclonal IgG antibody against IgE. It inhibits binding of the IgE to the FcERI receptors on the surface of the cell and the base of cells. Because it binds with FcRI component of the IgE, IgE cannot bind to the receptor on the cell. Then it can reduce the free IgE levels in the body, that there is less IgE deposited onto the mast cells. And only problem is omalizumab cannot bind to the receptor bound IgE. It can bind to the free IgG which is there in the blood. Infrequently associated with anaphylaxis when you are using omalizumab. The high cost of the treatment is prohibitive. In fact, 150 mg costs about 10,000 rupees. So dosage is 150 mg to 300 mg weekly, 4 weeks, about 12 years of age. This treatment can be given for those chronic urticaria who do not respond to the fourfold increase of the H1 receptor antagonists. So this is the mechanism. I am not going to the details. Morning it has been discussed very well. Next alternative is, along with the omalizumab, cyclosporin is a good alternative. In fact, it is a T-mediated immune suppression will be there, inhibition of basophil activity and mast cell degranulation will be there. And normally 3 to 5 mg per kg body weight along with daily antihistamine, and duration of the treatment is 1 month to 4 months. You have to monitor the renal functions and the blood pressure when you are using cyclosporin. So Montelukast, the word about the Montelukast, all the results trials are inconsistent. Sometimes may be beneficial due to the food urticaria because of food additives and NSAIDs. No added advantage over the antihistamines, and it may be reserved as an adjuvant in selected refractory cases. The routine use of Montelukast cannot be advised for the urticaria. The other molecule is doxepin, primarily a tricyclic antidepressant having H1, H2 antagonistic action. May be used in selected cases of chronic spontaneous urticaria and chronic inducible urticaria, especially when cyclosporin, omalizumab are unavailable or contraindicated. So other molecules, methotrexate, H2 blockers, first generation antihistamines, dapsones, UV lights, all have been tried, but the evidence is very low for them. So another is autologous serum therapy has been tried. Aspartate transferase has been tried for these patients for 8 weeks, but the results are and evidence is very low for usage of this type of treatment. So the consensus treatment in the Journal of Indian Journal of Dermatology has shown that only the cyclosporin and omalizumab are evidence of high grade, that is good, and the evidence is high for only these two molecules, cyclosporin and omalizumab, whereas other molecules, as far as the other molecules are concerned, the evidence is low, medium. So whenever the patient is not responding to the antihistamines, the next step of treatment should be with cyclosporin or omalizumab, rather than using all these medicines which have a very low evidence. So this is the flow chart for treatment of urticaria. So you should start with H2 receptor antagonists, that is second generation antihistamines. Fourfold increase can be done. If give a no improvement, you can give a short course of corticosteroids. If there is acute life-threatening presenting illness is there, then you can give short course of corticosteroids. And there is strong evidence as a step-up measure, cyclosporin omalizumab can be used. There is only weak evidence as far as first generation antihistamines are concerned, methotrexate, autologous serum therapy, and doxepin. These have only weak evidence, only certain specific cases where other treatments fail, you can use these drugs in the chronic urticaria. So take home points are, acute urticaria is commonly seen in infections and food allergy and having a good prognosis. Elimination of underlying cause whenever possible is essential to prevent urticaria. First generation antihistamines should not be used. Second generation antihistamines are the mainstay of the treatment for the symptom relief. Corticosteroids should be used for a short course if required. Autologous skin test is useful in autoimmune urticaria. Omalizumab is a better drug in chronic spontaneous urticaria, not responding to high doses of antihistamine. The other alternative is cyclosporine. The other drugs with low evidence may be used only in selected patients who are refractory to the treatment. Thank you very much for giving this opportunity. Thank you very much. Thank you, Ashwin. That finishes
Sir,
my
thank you for sticking to time, sir. You also spare 2 minutes, sir. You have two questions. Dr. Dheeraj Mohan Gupta is asking how many cases have presented as COVID cases have presented as angioedema.
have any such data as such because we have lot of there is one paper has been published, in fact, what are the skin manifestations of the COVID. I think last week 2 days ago,
Are there any presentation of angioedema?
seen 2 days ago, Dhiren Gupta has sent 2 pictures in the WhatsApp group. So though both of them have presented with edema of the foot and edema of the hands. So angioedema, it may be angioedema, or we do not know. Some extravasation of the plasma may be there like dengue, we do not know. But 2 days ago, Dhiren Gupta has sent 2 pictures of edema of the feet with a COVID positive child. So that means angioedema can occur with
What is the difference in presentation or management of European versus American Association of Management? Dr. Dheeraj Mohan Gupta wants to ask.
regarding urticaria?
Yeah, urticaria management in
Urticaria management,
American and European Association. Are there any changes in the management?
Exactly, I do not know. Whatever I have presented is the consensus statement of Indian Society of Dermatology, which has been published in the 2018 journal. So the difference between UK and US, exactly I do not know, really speaking. Is there any difference? If there is difference, I'll be happy to know. If there is, Dheeraj can tell us.
Ramakrishna Paramahamsa sir wants to ask, what is the presentation of urticaria in worm infestations in your private practice?
It is one of the
Urticaria
commonest
presentation, worm infestation, or worm infestation presenting as urticaria.
Cannot exactly correlate how many cases of urticaria will be there in the worm infestation. In fact, whenever there is acute urticaria is there, 90% of the times it is because of the acute viral infections. So parasites presenting as acute urticaria is not so common. In fact, though it is mentioned as etiological agent, there is no harm. If there is evidence of worm infestation, you can leave on the child presenting with urticaria.
Is an office bearer. Akuto Moshi is asking abdominal pain association with urticaria.
Yeah, abdominal pain is one of the commonest manifestation with urticarial. Whenever there is some dermal infiltration, I mean dermal extravasation is there, especially submucosal extravasation may also be there. Sometimes they can present with acute abdomen. When you give antihistamines, usually that will subside. In fact, even angioedema can present with GI manifestations of acute abdomen. I have seen 2-3 cases presenting a severe abdominal pain with the edema of the submucous. If you take a CT scan, you can find it, or an MRI may show that edema of the submucous layer. The only treatment is same as the urticaria. There is no specific treatment for that. They do present with acute abdomen.
A question from Arshad Hussain. How long do you treat acute urticaria with antihistamines?
Absolutely, this is a very important question. In fact, there is no problem. You can use these antihistamines for a longer period also. There are less side effects have been reported, and the dosage enhancement also 4 times you can enhance. You can use them till the urticaria disappears. If you are not able to treat them, at least 2 weeks response should be given. 4 to 6 weeks you have to use. If the still urticaria is very severe, not responding to the antihistamine, then only you should go for the second line of management. There is no problem as far as the
Treatment of papular urticaria.
as far as response is there, you can use them for prolonged period. But once the response is there, you should reduce the dose. Papillary urticaria
Treatment of
is same.
papillary urticaria by Dr. Tilak.
It is the same, in fact, same management, local calamine lotion and antihistamine, but it will take a longer time for the resolving.
Dr. Ramesh wants to ask, arterial vasculitis, can steroids be started early?
If the symptoms are very severe, short course of steroids can be given, but whenever there is vasculitis is there, you have to see for any other causes like autoimmune disorders are there, we have to look before starting the treatment definitely. Once if you diagnose specifically what is the cause of vasculitis, then you can start steroids in these conditions.
What is the commonest cause of urticaria in your practice?
It is infections. Post-infectious urticaria is very common. Most of the viral infections do present with acute urticaria. Apart from this, maybe some of the food allergies can present with urticaria, and some of the insect bites also. Most commonest is mosquito bites can cause allergy, which we see commonly for those patients who come from the US.
How often do you see hypothyroidism as presentation is chronic urticaria?
Yeah, sorry, Yashwant. Yashwant.
Hypothyroidism presenting as chronic urticaria.
Yeah, most of the times hypothyroidism is seen in the adults. In fact, children presenting with urticaria is very uncommon, whereas the adults with hypothyroidism can present with urticaria. I can see Dheeraj Mohan's answer is there. He says that American guidelines at first generation antihistamine plus montelukast if they are not responding to the 4 times dose of second generation antihistamines. But as far as Indian recommendations are concerned, usually the montelukast they do not advise as a step-up management for the urticaria. In fact, it is only the step-up of second generation is important. Only very few selected cases you can give montelukast. As such, there is a.
We go on to, thank you, sir. We'll go on to the next speaker. It's also a topic of interest. The speaker is Pawan, the secretary of PATS. He is now the associate professor of pediatrics at Bhaskara Medical College, MNR Medical College. Your attention to Dr. Pawan on atopy.
Yeah, thank you, Dr. Yashwant, sir. Just starting the presentation in a second. Yeah, thank you so much for introducing me. Dear friends, today we are going to discuss about atopic dermatitis, what a pediatrician must know. So we all know, because why atopic dermatitis is very, very important for pediatricians. Because the child presents right from the birth, that in the initial days, these children who come to us, and pediatricians have an enormous responsibility to identify this march at the beginning itself. That is at the stage of atopic dermatitis. This is the first step in the atopic march. We all know once the atopic march sets in, it's very difficult to halt the progression. And see, the eczema will start at the birth, and slowly later on the food allergies and asthma, rhinitis, and all this sets up. So pediatrician can really halt the asthma, the progression to from severe from the eczematous state to asthmatic state. If you don't identify these children at the early, that at the stage of atopic dermatitis itself, which we are going to discuss today, I think these children will, the progression goes on, and it is very difficult to halt that progression. Slowly they will be going to the rhinitis and asthma. The atopic triad, the famous atopic triad, was coined by the F.A. Koch and Kaki, both European immunologists. They have coined these terms atopic. And the atopic triad, we all know, the atopic dermatitis, asthma, and rhinitis. This triad usually is very important for that. And we are seeing, as the infections are going down, how these allergies and asthma is on the high rise. And in the Delhi, almost many children are, the prevalence is rising like anything. So at this stage, we pediatricians have an enormous role to identify them properly and to prevent the progression to the asthma. And we all know that the general population, if the general population of getting asthma is, if it is 8%, the children with moderate atopic dermatitis, they have the higher chance, that is 30% of them can be having the asthma in the future. But if it's a severe atopic dermatitis, these children are more likely to develop asthma to the tune of 70%. So as a pediatricians, if we can identify them early, avoidance of these allergens and all, and if we can control the atopic dermatitis, the severity, we can also control the progression to the severe asthma. And the association is all very proven. The studies, many studies says that 20 to 35% of the patients have asthma, and 34% of patients have allergic rhinitis, and 10 to 37% of the patients have food allergies. And remember, in a family, why? If you see the criteria, the family history or the personal history is very, very important. If the mother is positive, if the father is having a history of atopy, the child is more likely to get the tune of 30%. If the mother is also have atopy, then the chances of child getting is 40%. If both parents are having atopical history, then the chances are 60%. If the both parents have severe atopic dermatitis history, then though atopy, the chances of child getting is almost to the tune of 80%. So personal history and family history is one of the major criteria. That's why they have included. And if you see the pathogenesis, yes, these are the factors involved in the pathogenesis of atopic dermatitis. It is very complex pathogenesis. Remember, dear friends, xerosis, the dryness is the most important factor, and followed by the pruritus. Pruritus is the hallmark of atopic dermatitis. Any condition without pruritus, I think you can simply rule out sometimes, because atopic dermatitis is the itch that rashes, not the rash that itches. In the other scenarios, it is the rash which comes first and the child starts itching on the rash. But here the child, because of the xerosis and all, the child starts scratching, and after that the child gets rashes will be there. So it is the itch that rashes, not the rash that itches. And seeing the pathogenesis, there should be a skin barrier dysfunction and immune dysfunction, and the environmental factors, the genetic factors, and the pruritus is the main key. It has been involved in the pathogenesis. If this is being taken care, that's why it's very important for us to tell the parents to trim the nails, because they scratch more, damage the skin, and that will, if there is genetic preponderance and there is environmental factors that triggers, and that will result in epicutaneous sensitization, that will result in atopic dermatitis. See this? So what happens? This itch scratch cycle. This is a vicious cycle which always sets in. The allergy-mediated inflammation. So the dry skin is there, and that is xerosis is the hallmark, and which results in itching, the pruritus, and which results in allergy-mediated inflammation. Again, that causes dry skin, itching like that. How it causes dry skin? Here you see there is a transepidermal water loss, and the skin's inflammation makes the skin more vulnerable. It allows more of allergens, allows more water to escape. That's what's happening here, and the skin becomes dry and scaly, and that will lead to a lot of itching, and that causes more damage. So the cycle goes on. So this is in a nutshell how the irritants, allergens like dust mites, foods, and the irritants like weather, toxins, and the pH, which is very important, and microbes. Be careful about these, because they warrant sometimes antimicrobial therapy also, Staph aureus, and antifungal therapy because of this Malvasia furfur. And the itch scratch cycle can result in tissue damage, and that will result in the pathogenesis of this. So genetics and epigenetics play an important role. Even though genetics are there, if the epigenetics mechanisms like environment and other diet factors, if these things are not much there, then we can really control the atopic dermatitis. See how it is been the filaggrin gene and ceramides. These are very important aspects, and that will lead to immune dysfunction. All the TH helper cells, T regulatory cells are the important culprits here. So especially TH1, TH2, and TH12 and TH17. So these are the key T lymphocytes which are known to be there. So there are two types of ADs which are being very clearly mentioned. So extrinsic or allergic AD, atopic dermatitis, or intrinsic or non-allergic atopic dermatitis. This incidence is very less. Sometimes you can see in the children the normal serum Ig levels and skin barrier is normal. So the main thing is the Th1 dominant immune response is being seen there. But the most common thing is an extrinsic or allergic atopic dermatitis, where the incidence is almost 63 to 88%, and there will be elevated serum IgE. Not all, but most of the AD patients, they have 80% of the patients, they have a elevated serum IgE, and the disrupted skin barrier, and there is a filaggrin mutation, which is important, which can cause the defective skin barrier. So that will lead to Th2 dominant immune response in this mechanism. And there is a dual hypothesis, which has been very popular. So outside inside theory or inside outside theory, this is very commonly discussed thing. The skin barrier defect, that is outside, from outside to inside is the thing. So once the skin barrier defect because of a filaggrin gene mutation and all, so there is an allergy sensitization and the microbial invasion that will result in immune system activation. That the epicutaneous sensitization is very important for the atopic dermatitis, and that will result ultimately in the inflammation. So whereas from inside out approach, it is the mainly the immune system control failure, that is the T regulatory cells, there will be a there, and the Th2 response is high, and the resulting in pro-inflammatory cytokines leading to skin damage. So this is inside out. So coming to the famous hygiene hypothesis, nowadays in the atopic dermatitis and all, we are seeing how even the westernized countries, I think India is slowly becoming westernized because of small family size, affluent urban homes. We can see in cities how the atopic dermatitis incidence is increasing, and the intestinal microbial flora is also stable. There is a high antibiotic use and low or absent helminthic burden, good sanitation and low orophycal burden. This is the more these factors resulting in more allergic disorders to rise on the rise. But if you see in the developing countries, the other sect of the people where this the large family size, rural homes, livestock is there, intestinal microflora variable, and there's a low antibiotic usage, high helminthin burden, poor sanitation, and high fecal they are more likely, they don't have a lot of allergic tendency. So genes are there, but the environmental factors are what is deciding the which child has to have the allergic disorders, which children are non-allergic. So environmental, that is epigenetics, play an important role here. So whether the child has to become an allergy prone or a tolerance, they are developing an immunotolerance. This is mainly Th1 cells or Th1 balance side or Th2 balance side. This is mainly which inflammatory mediator should be secreted. That is mainly dependent on what is the exposure, initial exposure. If the initial exposure is through skin of these, peanuts and, all these things, if the milk and all, if the sensitization is, epicutaneous sensitization is happening, that is triggering dendritic cells, and, these resulting in Th2 memory cell activation, resulting in IL4, IL5, and IL3. These things are increased. So that will result in atopic dermatitis. But if you are, if the sensitization is happening through oral, all this sensitization is happening through oral, that will trigger another different mechanism leading to Th1 memory and T regulatory memory cells. So that will lead to tolerance, immunotolerance. So dear friends, that's where the LEAP study, the famous LEAP study, where their early introduction of peanuts at 4 months itself will have a protective effect on the children. So coming to the typical progression, we all know that if you see the diagnosis is mainly clinical. Definitely there is no tests which confirm the diagnosis of atopic dermatitis, but it is mostly clinical. So when it comes to clinical, we need to know what are the areas which are being frequently distributed by this, and how we need to identify. So the characteristic feature, usually the atopic dermatitis, they present much early in infancy itself. And if you see in the initial stages, the child will be having the rash on the cheeks. That is mainly because when the baby is breastfeeding, because of xerosis and all, the child starts rubbing to the mother's breast, and that will result in the rash on the cheeks. When the child starts, walking and crawling and all at 6 months, the extensor surfaces are more involved. That's where, because of rubbing and all, the friction and all, so there is a cause of damage, and the extensor surfaces are more visibly seen. And later, the flexural surfaces are most commonly involved when the child starts walking, sitting and all. So these are the different areas. The flexural areas are the later on. Here it's being clearly seen, eczema on the back of knees and all. So acute eczema in AD and subacute eczema. These are the different manifestations they present to to the pediatrician, severe xerosis in atopic dermatitis, subacute eczema on the both limbs. 1 second. Yeah. So this pityriasis alba is a minor criteria. So if you see Hafkin and Rajka criteria, there are out of 4 major criteria, 3 should be there, and 3 out of almost 26 minor criteria are there. So for a pediatrician, I think it's very difficult to remember all those things. But you remember pruritus, family history, typical distribution of rash, and the chronic relapsing nature of the disease are the major criteria for this. And the P. alba, Denny Morgan fold, this comes under minor criteria. Coming to the treatment option, which a pediatrician is mostly interested. So I think we are not, pediatrician should be sufficiently endowed to treat this atopic dermatitis. We should not refer to dermatologist unless it is a mandatory thing. So what are the main treatment goals? If you see, the main treatment goals are prevent exacerbation, treatment of comorbidities, treatment of complication, minimal adverse effects, and improve the quality of life. This call improving the quality of life is important mainstay. That's where the pediatrician role plays. And if you see, it's if the child is having atopic dermatitis, it's not the child alone who suffers. It's the entire family who suffers, because the child of severe atopic dermatitis will be very cranky. The whole family, they will spend with the sleepless nights, and the psychosocial education is very, very important. So what are the common triggers? Because of the dry skins, the irritants, the emotional stress, allergens, heat and sweating, and common infections like Staph aureus and Malvasia purpura. These are the trigger factors which we need to keep in mind and which we need to try to prevent. So this slide totally summarizes what is the management of atopic dermatitis is in a hierarchical manner. So the main principles of management are emollients need to be the first line in the treatment of atopic dermatitis, and that will result in emollients are very essential for epidermal barrier repair. If you can see, and the trigger factor avoidance, identifying the triggers and avoidance or elimination of the trigger factors are very, very important in the management of atopic dermatitis. So we all know this, and the dietary changes and topical corticosteroids and topical calcineurin inhibitors and phototherapy or systemic immunosuppressants in severe AD. I think for a pediatricians, if you remember till this point, topical corticosteroids and calcineurin inhibitors, I think this is more than sufficient. So that main treatment goes in, like, as the severity of the disease increases, this is how the pyramid goes on. So the mainstay of treatment is the prevention of flares prevention or the maintenance. So for that, daily emollient is very, very essential. Very crucial is this. So cleansing, bathing, and emollient use is same for all. It goes for all, whether the child is a mild atopic dermatitis, moderate or severe atopic dermatitis. The cleansing mechanisms, bathing regimen, and emollient use is a strong basis. So daily emollient use, liberal use of emollient, and allergen avoidance and elimination is the mainstay in preventing the flares and the maintenance. And coming to the mild and transient AD, what is most important is the mild topical corticosteroids. So there are a lot of dilemma in the patients that steroids are bad. But in such conditions, if because the mainstay, if you see any failure, any atopic child who has failed in the treatment, that is mainly because of inadherence to the treatment because of steroid phobia and all. I think we as a pediatrician should counsel them. We should tell them that is what it is, and we should counsel properly. Otherwise, if they come to know later that it is the steroid is what is being prescribed, then they immediately have high chances of stopping the treatment. But if you pediatrician, you took them into confidence and tell them that there are good steroids and bad steroids, and these topical steroids is the mild ones which we are using. So if you are able to convince the parent, then only the success of the treatment lies in that. So antiseptics, if you are suspecting any microbial coexistence, and the non-sedating antihistamines are very, very in initial days. But if the child who is having a intense pruritus and disturbing his sleep, I think it is a sedating. The first generation antihistamines are the mainstay. The hydroxyzine and diphenhydramine are the mainstay there. But coming to the moderate atopic dermatitis or recurrent atopic dermatitis, try to use a moderate topical corticosteroids and sedating antihistamines here, and topical calcineurin inhibitors and emollient. Emollient's always the mainstay for all. So please remember that. And for the persistent AD, severe persistent AD, I think the potent group of topical corticosteroids, systemic therapy also, sometimes short course of systemic therapy also needed. And the phototherapy and oral treatments are also there, which we will be discussing. So this in a nutshell of the treatment of the atopic dermatitis. Coming to the one by one, if you see, it is focused mainly on the emollients use. The moisturizer and emollients are very important. The mechanism of action being they increase the hydration of the epidermis primarily by acting as an occlusive layer, preventing the transepidermal evaporation. That is the main mechanism of action of the emollients. So these moisturizers or emollients, I think, are they interchangeable, emollients or moisturizers? No. Moisturizer is a broad class of group. It's a broad class of group in which humectants, emollients, and occlusives. These three are there as a subdivisions. So emollients are the cornerstones of maintenance of skin therapy in atopic dermatitis, and they hydrate the outer layers of skin. They prevent the transdermal evaporation, and they provide a protective layer on the skin to prevent water loss and penetration of allergens, and recommended to be used as the basis of care for all severities of atopic dermatitis. I'll spend more time on this because emollient use, I think we pediatricians are more prescribing the steroids and all. But if a pediatrician counsels the parents about the role of emollients, the moisturizers, I think the parent who is using emollients regularly, there is a 70% chances that you can reduce the use of steroids and all. So that's why we need to stress more time and given a very good knowledge about the emollient use to the parents. So So coming to the recommendation, what is the selection? Yes, you always used to select unperfumed or without a colorant, cosmetically acceptable to the patient. That's very important. And what are the formulations available? Ointments for chronic dermatitis, always use ointments which have a longer duration of action. And the cream or lotion for acute weeping dermatitis or hair-bearing areas, use cream. And aqueous cream should always be avoided. How to apply? Yes, apply twice daily. You can apply thrice also. So this dose, I think, I don't think any parents will apply 250 to 500 grams per week all over the body, and use during bathing, showering, and restrict use of shampoo or bubble bath. Apply using smooth strokes. Do not rub. That is very important. We don't want any harsh rubbing there. Use on the affected area even if it is no longer visible, and suitable to use under occlusion because on the particularly areas of xerosis, used as a occlusive therapy. When used in combination with topical therapies, wait several minutes before between each applications. So don't apply immediately. You need to space it out. So remember, friends, always tell the parents the rule of 3 there. The rule of 3: bath for 3 minutes. Bath for 3 minutes. Apply moisturizer within 3 minutes and apply 3 times a day. So please tell them the way so that they will remember in a nice way. So what is the basic skin care? We all know that it is the mainstay in the treatment of atopic dermatitis, which is resulting in restoration and maintenance of epidermal skin barrier. And so the classical agents are used in the basic therapy are urea, glycerin, and ceramides. So these 3 compositions, when you are choosing a right moisturizer, please look into these compositions which are there. Ceramides are the natural components. If they are deficient, I think this will help us. So so when we see in the pack, if you see that this moisturizer contains urea, they usually brief you, so they brief you that it contains olive oil, it contains urea, it contains glycerin and ceramides. So these ceramides are the essential components of lipids in the stratum corneum. You have seen in the picture in the beginning. And if they are deficient, they are definitely deficient in the patients with atopic dermatitis. That's why the moisturizers which contain ceramides, they have a very good role in the long term as a good emollient. Coming to the glycerin, yes, glycerin promotes the hydration of the stratum corneum, and it decreases the transepidermal water loss, which is one of the pathogenesis in the thing. and clinically effective against pruritus. Glycerin-based things they are clinically effective against the pruritus. Coming to the urea, which is very, very good one in the barrier regeneration, hydration of the stratum corneum, decrease in the transepidermal water loss, steroid sparing effects, reduction in the SCORAD index, and antimicrobial properties are all have this urea. So the components of the natural moisturizing factor, that is NMF of the epidermis, it contains the component. So it hydrates the stratum cornea and it reduces the SCORAD index. This is very important to understand. I think better to choose one with the urea as a moisturizer. The mainstay, again, the mainstay of treatment is if you go for the treatment therapy, it is topical corticosteroids are very essential for controlling pruritus and suppressing the inflammation and restoring the skin barrier. This is important factor for that topical steroids are used, and it may inhibit many aspects of inflammation which are the crucial in the pathogenesis of atopic dermatitis. So they also results in nerve growth factor reduction and also helps in the relief of pruritus. That is another good thing about topical steroids. And the potency of topical corticosteroids should be selected based on the severity of AD. So we all know there are 7 to 8 types of different potencies of topical corticosteroids. So always better to start with the low potency one. So there are low potency one, intermediate to high potency, halogenated one, ultra high potency, like that. So while choosing topical corticosteroids, it's very important that maintenance therapy to prevent exacerbations, low potency you need to maintain. And for intermediate and high potency, you use them for during exacerbation for a very short period or for a proactive therapy. And ultra high potency, no more than 1 to 2 weeks, and they are used only on the non-facial, non-skin fold areas. Especially when you use in the folds and genitalia, please don't use high potent topical steroids. So potent fluorinated corticosteroids should not be used on the mucous membranes, face, eyelids, genitalia, and intravenous areas or in young infants beyond a few days. So what happens if you are if the parent are you usually write a protocol that therapy should be used for 1 week or 10 days, or if you use for proactive therapy, you advise for 8 weeks, 10 weeks, like that. But if the parents found that why to go to the pediatrician, this is a recurrent problem, you are applying that, and again, the inappropriate use of topical steroids. If you see the patients have the poor knowledge of the steroid class potency, that's why it leads to inappropriate use of these medicines. So patient concerns about the using topical steroids, they usually think that it causes harm, but we need to explain them how the benefits outweigh the risk. And the long-term repeated use of topical steroids may develop in the adverse effects and dependence. That's what usually they have the thought. And poor adherence to therapy rather than the disease severity is the major cause of treatment failure. That's why counseling plays a role, important role here in convincing the parents while you are prescribing topical corticosteroids. So this I learned from the pediatric dermatologist. So the proactive therapy of atopic dermatitis is an emerging concept. Now it has already emerged concept now. So it starts with an intensive topical anti-inflammatory therapy. I think this is a tip for the pediatricians. I think we won't do that. Whenever the patient comes, we will advise the moisturizer and the topical steroid, and they apply for 1 to 10 days. And once it subsides, they stop using it. But see the proactive approach, this is a revolution in this treatment actually. So it starts with an intensive topical anti-inflammatory therapy until all lesions have mostly cleared. And then you don't stop there, but you follow up with a long-term low-dose intermittent application of anti-inflammatory therapy to the previously affected skin together with the daily application of the emollients. So you will be asking the parents once for 1 week to 10 days or till it subsides, maybe 2 weeks, to apply daily, twice daily. And after that, don't let them stop it. So weekly twice, like Wednesday, Saturday, or Wednesday, Sunday, or Saturday, Sunday, 2 days a week. If you keep on apply the these topical steroids only on the affected areas, so and the emollient should be applied on the unaffected areas, I think that will give the proactive approach a great success. So there is an overwhelming evidence that normal-looking non-lesional AD is not normal at all. So, but it is characterized by the
5 minutes to go.
Barrier function.
5 minutes to go.
Yes, sir. Yeah. So this is how a reactive management and proactive management. See, the idea of proactive therapy is we are not only suppressing the flares here. We are addressing the subclinical inflammation and we are achieving the normal skin here. The subclinical inflammation is being addressed thoroughly in the proactive therapy. Coming to the topical, this is a summary summarizing that. So sufficient strength, sufficient dosage, and correct application is the key cornerstone in the effective topical therapy. So how long can it be done? Proactive therapy is up to 20 weeks in the trials. We have seen almost 20 weeks the proactive therapy being addressed. Okay. So next is topical calcineurin inhibitors. The addressed ones are the pimecrolimus and tacrolimus. Pimecrolimus is you can use in less than 2 years. So this is available as 0.1%, and this is 0.03% is advisable for children. Tacrolimus. So these topical calcineurin inhibitors are important anti-inflammatory drugs to be used in atopic dermatitis. So this is like a steroid-sparing drugs. Okay. So instead of treating acute flares with TCI, initial treatment should always be with topical steroids before switching to TCI. And they're especially indicated in the sensitive skin areas. Remember, we told you that we should not use it for face. Steroids should not be used for integral and anogenital area. But whereas TCIs can be applied, and effective sun protection should be recommended in patients treated with TCI. So these are the American Academy of Allergy and Immunology and AAD guidelines, which clearly says that TCS should be recommended if AD is not controlled with moisturizer alone. So first try moisturizer, that is the integral part of the treatment as recommended as the first line of therapy. Then it's not coming, then low potency TCS, and they're recommended for maintenance therapy, and intermediate and high potency are recommended for short-term exacerbation and all. So that risk we should be outweigh and tell that. And coming to TCI, they are considered for the management of AD. So they should be considered for delicate areas, which I already discussed, and it should be counseled regarding the potential for localized burning, itching for the during the first week. So these guidelines are there, very much there. And the upcoming topical therapies, I think the dermatologists are very much using now this crisaborole, topical selective phosphodiesterase 4 inhibitor. These are the upcoming treatment, topical Janus kinase inhibitors. Phototherapy is very commonly used now. The recent evidence also confirmed that 74% patients having a mild to moderate AD, they showed the complete resolution, while 16% showed improvement in during summer holidays. So this is the basis for the UV radiation therapy. So the mechanism UV therapy, and it clearly says that it relieves the pruritus in AE patients. And the RCTs depicts that narrowband UVB and UVI, which are the most effective therapy modalities in the treatment of atopic dermatitis. So the recommendations are also there that UV therapy can be used to relieve pruritus, and narrowband UV, this is the most preferable treatment modalities. So one important factor about this cosmetics and detergents, we all say that ask the parent to use syndered soaps, not soaps actually. Soaps increases the pH for at least 60-90 minutes, which causes an impairment in the skin barrier and consequently increases the intensity of atopic dermatitis. Dear friends, please make sure that the parent uses the syndered soaps to the child. Syndered soaps are nothing but synthetic detergents. They are like soapless soaps. So they maintain the pH around 5.5, which is very crucial for the skin environmental, microenvironmental barrier function. So bleach baths and wet wraps, yeah, I think we won't advise, but dermatologists, they advise this. So this is how a wet wrap therapy should be done. This is for severe atopic dermatitis. So I think I'll just, with this slide, I'll conclude. So the new clothes containing high levels of formaldehyde, we should tell the parents that the practical tips. So always don't put new clothes to the child because that causes irritation to the skin. They should always be used, washed before use. And washing powders, if they remain in the clothes after laundering, they will be highly irritate the skin. Please do that with a dry, normal water. And the air should be adequately humidified. The right temperature for the children is 18 degrees centigrade, and the humidity should be 50%. That is the right temperature for the AD patients. So frequent baths should be avoided, especially with hot water. Just lukewarm water should be used. And if you see the certain factors like sweating, dry skin, physical efforts, emotional stress, wool, synthetic fibers, hot water, and certain foods can aggravate itching. So, and the proper cooling of the skin can control itching. That is what 18 degrees centigrade is a good temperature for them. So with that, I'll just conclude. And what is the certain foods can we prevent AD? I think before closing, I'll tell you, or can we prevent atopic dermatitis? Yes. If you tell the pregnant mother and lactating mother to avoid egg, fish, milk, peanuts, nuts, and wheat items, sometimes you can prevent. And there is a delay if you introduce these solid foods. Breastfeeding has a protective role here. If you delay the introduction of milk by 1 year, egg and and wheat till 2 years, and nuts and fishes above beyond 3 years, you can really you can prevent the atopic dermatitis. With this, I'll conclude. Over to Yashwant, sir.
Thank you, Pawan, Dr. Surendranath, and Jakka Srinivas. I request Pawan to answer the questions and chat box. We are running short of time. I will hand over the mic to Sri Krishna for further talks. The talk was excellent, Pawan.
Thank you,
All
sir.
the three have
Thank
done
you.
justice and stuck to the time. Over to Sri
Thank you
Krishna.
so much, sir.
Thank you, Dr. Yashwant. Thank you, Dr. Yashwant. Acknowledge the presence of Dr. Narahari, unfortunately, who could not join. Pawan, you have a minute to quickly sum up the answer to whatever you find in the chat box.
Yeah, dyshydrotic eczema is due to atopic dermatitis or duration of corticosteroid use. Yeah, corticosteroids use. Yeah, corticosteroids used in atopic dermatitis in the clinical practice, what we see is almost all, this proactive therapy, once I think it will reduce the number of flares and the duration also. So till now, I think I have used only to the tune of 6 to 8 weeks in the proactive regimen. And dyshydrotic eczema, yes, they are like a focused eczema. It is also one sort of atopic dermatitis. And please suggest commonly available Syndet soaps. Yeah, there are many Syndet soaps which are available with pH 5.5, sir, like the Cetaphil Syndet soap and Teddy Bar and all those things. They come with a Syndet regime. And role of immunotherapy in atopic dermatitis. Yes, this is an evolving thing. Atopic dermatitis, it has a very good big role in treatment of atopic dermatitis. Once you find the allergens and all, so immunotherapy has a very good role in preventing atopic dermatitis. So what is the evidence in the delayed introduction of these certain foods will prevent AD? Yeah, yes, ma'am. That LEAP study is the one which is totally says opposite. That early introduction of peanuts by 4 months. That is the recent study. I think recently it has concluded, and we found that results of LEAP study says that if you introduce what are the suspected allergen through oral route rather than the epicutaneous sensitization, if you divert that to oral route, then that has a more protective effect than if the child gets it to the tolerance is more compared to then the child goes to the allergy side. Yeah, fluticasone, both are better. Fluticasone versus mometasone, both are better. I think both have a very minimal side effects profile.
30 seconds, Pawan.
Yeah.
Yeah, request you to please type the answers in the chat box. Last question.
Yeah, 1%
you missed one point which was raised by Dr. Arjun. When you refer it to your wife?
Yeah, only in severe atopic dermatitis I'll be referring not for. Previously, I used to refer almost every case, but now I think
combo pack, Pawan and Madam.
Yes.
All right, so we'll end on that note. Thank you, Dr. Pawan, and the speakers of the first post-lunch session. Now we come to the last session of the evening, and very exciting talks. And I now invite Dr. Arjun, the president of IAP-TCB, and Dr. Vamshi, the treasurer of IAP-TCB, to chair the last session and take things forward. Over to Dr. Arjun.
Thank you, Dr. Krishna, Dr. Pawan. From 9 o'clock on the dot you started. It's been an exhaustive, comprehensive coverage of all allergic diseases in children. And we could hear all the experts from across the country, and especially Professor Major Nagaraj also address and give his talk. And a good mix of young and the veteran speakers on allergy diseases were there. So it's been hugely successful CME, a day-long CME with great hours, and thanks to Naran Reddy, Dr. Altaf and his team at Deccan, they made it possible. So it's wonderful going. Of course, we are making use of the COVID times. Nevertheless, despite battling all these diseases, my appeal is to everyone to gather up and garner and start treating COVID patients, either home care or whichever care possible. So we should stand by the community and the government and help every COVID victim. So anyway, now getting on with our last session. So last session, we have wonderful speakers. We have our own Dr. Arif Ahmad, the veteran allergologist, pediatric allergologist, who is one of the forefront allergologists of Twin Cities, and is authored quite a few books and given so many lectures and in various fora. And young and dynamic Dr. Suman is there, the allergologist from Ankura Group of Hospitals. He's our EB member also. Dr. RSV, once again, another our Dynamo secretary, was going to talk about prevention of allergic diseases. As you know, as the industrialization and everything, the allergies are on the rise, and it's almost occupying about 25% of our practice. So it's so vital that we should have had this kind of a day-long CME covering all aspects. I'm sure the youngsters, all the practitioners have got benefited out of this. So Dr. Vamsi, you kindly would you like to introduce the speakers? Vamsi? Hello? Hello?
Vamsi, you need to unmute your co-host. You can unmute.
Yeah. Am I audible?
Yeah.
Yes, go ahead.
I welcome wonderful speakers, Suman and Arif sir and RSV for this is a most interesting topic, and a record number of members have been registered and made this successful talks go ahead. Thank you for giving me opportunity for chairing the session with my president, Arjun sir. Thank you, sir. So without wasting much time, I would like to call upon the Arif Ahmad sir.
I think the first talk is Dr. Suman's difficult.
Suman, you can start.
Difficult asthma to be treatment of difficult asthma.
Thank you, sir. I will just take over. Thank you. I think is my screen visible right now?
Yes, it is visible.
Thank you.
It is visible.
Thank you, sir. Thank you. Thanks a lot. Thank you, everyone, especially IAP TCB for and PATS for giving us an opportunity to conduct a day-long allergic CME. And I thank Narayan Reddy sir for his effort to get credit hours for allergic CME. It's a dream come true for us, for allergologists, to have a day-long CME. And there were exciting talks in the morning. It was quite enlightening for most of us. There were a lot of learning points for us. So without wasting much time, I'll get on to the topic straight away. We all manage asthma. Now, diagnosing asthma is not a big deal. Thanks to the IAP programs across the country, across various forums. Now, diagnosing asthma is not a bigger challenge as it was a decade back. Now, I think we can at least understand the difference between asthma, what is asthma and what is not an asthma. Now, the challenge lies in the management of asthma. You give certain medications for asthma. You give treatment as per guidelines of asthma. A lot of GINA guidelines, a lot of guidelines are being taught. So you go according to it, and the patient doesn't get better. They keep coming back again and again and again. That is where the challenge lies. So what are we supposed to do at that time? So that is what, looks like this. So when a patient keeps coming back, when you give a routine treatment according to the GINA guidelines, and the patient keeps coming back with recurrent exacerbations, and it doesn't respond to your regular treatment, it looks like this picture. You won't understand. It looks very complicated. That's when we call it as difficult to treat asthma. So why is it important for us to know difficult to treat asthma? When we know asthma, why is it important to understand difficult asthma? Because you can argue that very few children get into the last stage of treatment. Majority of the children will be in the first 1 to 2 stages of treatment. You are absolutely right. But why is it important? Because the global prevalence of difficult asthma in children is nearly 5%. So out of every 100 children who suffer from asthma, 5 children get into the last stage or the highest stage. That is something which we need to keep in mind. If we don't know how to manage that, then I don't think we'll be in a position to manage asthma properly. Yes. And secondly, if these children are 20 times more likely to be admitted in hospital and 15 times more likely to visit an emergency room. So these are the children who might get admitted again and again. So normal asthmatic children, very unlikely to get status exacerbation if managed well. But if these children who are normally on the highest stage, these are the children who are prone for admission. These are the children who might suffer from a near fatal asthma. These are the children who might require highest dose of steroids. These are children who might suffer from severe side effects of asthma. So that is something which we need to keep in mind. That's the reason why we need to understand this disease much better. So what is the WHO definition for difficult asthma? See, there are actually two types based on the control. So if we get a very good control at the highest level of recommended treatment, means it requires the highest level of recommended treatment, that is when we get a good control. We call it as a corticosteroid resistant asthma, means unless you get to the highest level of treatment, sorry, I mean to say if you reach the highest level of treatment, but the patient doesn't respond to the highest level of treatment, we call it as a corticosteroid resistant asthma or a refractory asthma. Means you give almost 800 micrograms of budesonide inhaler for a child below 12 years, and above 12 years, you go above 1200, still the child doesn't respond. You give oral steroids, still the child doesn't respond. That is when we think about it as a refractory asthma. We need to look further. Or we might come across a situation where the asthma is only controlled with the highest level of treatment. You get into the last stage, then only the patient is fine. The moment you start to decrease the level of treatment, decrease the amount of steroid, the patient starts getting recurrent exacerbations. We call this condition as difficult to treat asthma. So there are two types, either it is difficult to treat asthma or corticosteroid resistant asthma. Now, what is the diagnostic criteria? As we could see it, there is a major criteria and there is a minor criteria. If a child requires continuous repeated oral bursts of steroids, more than 50% of the year, means every other month, he is requiring steroid bursts or emergency visits where he's being given IV steroids or oral steroids or systemic steroids, then yes, or highest dose of inhaled steroids most of the time, then it is considered as a major criteria. We consider it as a, most of the time we consider it as a difficult to treat asthma. Or the child is requiring almost a daily need of reliever therapy. Means at least more than 3 times a week, the child is requiring daily reliever therapy, and controller therapy is through and through the year, and is daily requiring this and beta agonist, and is having more than 1 ER visits every 3 months. Whenever you have more than 1 ER visit in 3 months period, you need to look beyond asthma. You need to look if there is anything, our treatment is not enough, anything we need to change. Or more than 2 to 3 oral steroid bursts a year. Anything of these is there. So either it should be 1 major criteria or 2 minor criteria to call it as asthma. And even if you give more than 25% of daily oral or inhaled corticosteroid, the dose, the patient doesn't respond well. And if his FEV, when he's checked, above 5 years child, is always less than 80% despite higher regimen of treatment, and he suffers from a near fatal asthma, where he's ventilated, he's on the highest dose of ventilation, and he's kept on severe drugs such as magnesium sulfate and ketamine. That is when we consider it as a uncontrolled asthma or a difficult to treat asthma. What are the different types? If you can subclassify, it is untreated severe asthma. This is a condition which is very common, because why it is quite common is whenever we, especially in tertiary care centers, is these children are managed for the recurrent exacerbation with nebulized solutions or oral steroids intermittently and randomly over a period of time. And their airways become so narrow that they end up coming to the ER with a near fatal asthma. That is what we call it as an untreated severe asthma, where they don't respond to your regular steroids, systemic steroids, where you need to step up the steroids and you need to give a lot of medication. The child might require ventilation. So we call it as untreated severe asthma. This is something which we can avoid by diagnosing and picking up asthma quite early. And then we come across difficult to treat severe asthma, which I've said, where you require highest dose of inhaled steroids, recurrent oral corticosteroids to get a good control. Or you get a state where, despite giving the highest stage, the child doesn't respond to the treatment. We call it as a treatment-resistant severe asthma. What is important as far as the diagnosis, whenever you come across a severe asthma, no need to get confused, because they might visit various pediatricians, they might receive various inhalation doses, they might come to you. Almost always the golden rule is, whenever you come across any case of allergy, not only asthma, the golden rule is 90% of the diagnosis can be made through a proper history. First and foremost, when you manage the child, look at the child and ask a question: is the diagnosis correct? And rule out an alternative diagnosis. If I can give an example within this short period of time, when I was working in a tertiary care hospital, so I got a case from Nanded, which is Maharashtra. So where the child was kept on inhaled corticosteroid, and he was given recurrent bursts of oral steroid because his wheezing was not subsiding. So he was almost on the highest dose of inhaled corticosteroid. And the child is absolutely stable otherwise, absolutely healthy. He doesn't have any nighttime attacks, and he's quite comfortable, but his cough is persistent and his wheezing is persistent. That was a complaint. The child comes to my office and they give the entire history, and they say that, it started, the child was 12 years old. It started all of a sudden just 3 months back, and already the child was on the highest dose of steroids. And all I have to do is ask all the history, which was not at all matching with a regular asthma because he's never relieved. So all I have to do is put the stet on his chest. Right side, there is a significant monophonic wheeze, and then shift my stethoscope to the left side. There is absolutely no wheezing. The air entry is absolutely fine. We got a CT chest done, and it turned out to be a foreign body, and the foreign body was taken off, and the child is absolutely fine. So this is something which we need to keep in mind as pediatricians, that we need to auscultate all areas of the chest and go by the diagnosis. Asthma just doesn't come like that and stop responding for a healthy child who's sleeping well, who doesn't have any night attacks. That's something which we need to keep in mind. Second thing, what we need to keep in mind is the patient complaint. You have written the right dose, you have written the right diagnosis, you have done everything, but is the patient taking the medication? Most of the time, it is already proven that more than 60 to 70% of the time, especially in a country like India, where patient education is very poor, the moment the patient is relieved of symptoms, he will stop taking medication. And more than 80% of the people, moment they complete 1 month of treatment, they're trying to stop their treatment. It is only 20% who are highly compliant. That's the reason why you need to ask the patient to come for regular follow-up, and tell them to come with the inhaler. Tell them to show the technique every time they come, and tell them to look at now inhaler has a dosimeter. Look at how many doses the child has used. How many times did he use the reliever? How many times is he using the controller? How many doses are left? That is something which we can look into. And next question you have to ask is, are there any trigger factors in-house? If the child is below 2.5 to 3 years or 4 years, or he's just joined a school recently, obviously he will be having a lot of viral infections, which would trigger infection. He's already a known asthmatic, and the viral infections over and above will cause more triggers. And look at the surrounding environment. He's living nearer to the road, then air pollution can be a trigger. And look at the kind of lifestyle the patient is living in, kind of pets, they're living in living rooms and bedrooms, or the bed sheets are not changed at all. They live in a clustered environment, too many people are there. Then you need to take the factor that, trigger factors are something which we need to keep in mind, because if you don't keep them under control, the child is unlikely to respond to your regular treatment. There's no point in increasing your treatment without focusing on the trigger factors. So if you can just take care of the allergens, let it be dust mite, let it be cockroach, let it be fungi. These are 3 most common allergens, indoor allergens. And you also look into the air pollution aspect. If you can take care of it, 80% of the allergens can be managed. If the 80% of the allergens can be managed, automatically your asthma treatment would be much better. And third important and really important one is a comorbid. See, everything starts from the nose. Everything is interconnected. Whether it may be your nose, it might be your ear, it might be your esophagus, it might be your lungs, it might be your trachea. Everything are interconnected some way or the other way. And you cannot treat them separately. Just because a child has adenoid, just because the child has sinus, you can't just leave them to the ENT and you separately manage asthma on your own. You need to work in coordination with the rest of the team and try to see that even they are controlled well. See, if a child is mouth breathing, automatically what happens, his entire reflex phenomenon get disturbed. Automatically his protective phenomenon goes for a 6, and the child is unlikely to respond to your asthma treatment. So we need to ensure that the child doesn't suffer from allergic rhinitis, adenoiditis, or any associated features such as GERDs. And as we know, 80% of patients with asthma, 70 to 80% of patients with asthma will have coexisting allergic rhinitis. And 30% of patients with allergic rhinitis will definitely have asthma. This is something which we need to keep in mind. So if you don't manage allergic rhinitis, unlikely we are going to manage asthma. So are there any psychosocial factors which we need to keep in mind? Bigger the child, they will have apprehensions of carrying the inhaler to school. They'll have a lot of factors, and something which we need to keep in mind. Parents themselves have a taboo of declaring the child as asthmatic, so they will be hesitant to use it, so their compliance would be very low. That's something which we need to keep in mind. Or the child has certain other psychological issues. That's something, the child compliance will automatically go down, which is something which we need to keep in mind. So history becomes the cornerstone in management of difficult to treat asthma or steroid resistant asthma. Then obviously, as I said, rule out alternative diagnosis. Take a proper history. Asthma is a diagnosis once you ruled out all alternative diagnosis. Whatever diagnostic methods we use is only to rule out alternative diagnosis, not to diagnose asthma, as a matter of fact. So you rule out congenital malformations, if any, for this child, which might have, triggered these events, which doesn't allow the child might be suffering from bronchomalacia, conditions like tracheobronchomalacia, which might look like asthma, but it is not asthma. Child might be suffering from Kartnagar syndrome. Child might be suffering from cystic fibrosis, which might, recurrent infections, recurrent wheezing might confuse us, thinking that, it can be mostly asthma. Or there might be a tracheoesophageal fistula. There might be severe laryngomalacia, something which we need to keep in mind. And as I said, foreign body has to be ruled out. You need to check all the corners. You need to look at the history, family history, the personal history. When did it all start? Child was absolutely fine. Suddenly child starts to cough and cough continuously, and there is a monophonic wheeze. Think about it, because asthmatics, mostly it is polyphonic wheeze. Vocal cord dysfunction sometimes mimics asthma, and it is not common in children below 12 years. It is more common in children above 12 years. And GERD is quite common in children, especially smaller children or younger children. And because of the frequent lifestyles we are having, GERD has become more common in other children, especially obese children. Also, the GERD has become more common. A GERD is one thing which can trigger asthma symptoms because of microaspirations. You do n number of medicines, child doesn't respond. The moment you keep an antacid to the child responds to the treatment. So a proper history to ask, if the child's cough increases the moment the child takes feed, after taking feed, is it related to his feed? Connect him to GERD. CHT and PPHN is something you can rule out by history. Bronchiectasis is more common about 9 to 10 years, has to be ruled out if it is unilateral most of the times. And cystic fibrosis, because what happens in bronchiectasis and cystic fibrosis or CHT and all these conditions, the child will be having failure to thrive. The child will not thrive well. Here in asthma, it is mostly the well-looking child which you look at. That is something which aids you in differential diagnosis. So other comorbid conditions, as I said, like allergic rhinitis, sinusitis, GERD, obesity, CHD, and psychological factors also should be looked into. And obesity has become a significant factor thanks to lockdown, thanks to prolonged quarantine by the children. The obesity has drastically increased in children. Children have increased drastically. And what happens in obesity? What is its relation with asthma here? The regular treatment doesn't work in an obese child as it works in a normal child of that same age. Because of the mechanical factors, the lungs don't expand. And because of the leptin gene, there will be a lot of pro-inflammatory markers which will be released, which itself causes inflammation in the airways and which causes difficulty in management of asthma. So we need to say to the child that, child needs to be active and his weight needs to reduce in order to manage. So there are many phenotypes as far as severe asthma is concerned. As I said, it can be a refractory asthma, difficult to control, I have already said, or a poorly controlled asthma. Because of the lack of compliance, lack of proper drug dosages, lack of proper diagnosis, or steroid dependent or steroid resistant asthma. I said the child has to depend on higher dose. The moment you taper him off inhaled steroids, the child starts to have all the symptoms. And brittle asthma is not common in children. It's more common, in adults. Basically children who have a small airway problem. These are the patients who suffer from severe, respiratory attacks. They look absolutely fine. All of a sudden, they have a very severe attack where they require the highest dose of steroid. And irreversible asthma is a condition where, despite the best of the treatment, the child doesn't respond to your regular treatments. The child continues to wheeze. And fatal, near fatal, where the child would be ventilated or requires the highest dose of medicines along with other medications which are required for bronchodilation and anti-inflammation. So these phenotypes are divided based on the control. If it is when controlled with maximal therapy, we call it as severe therapy responsive asthma. If it is poorly controlled with maximal therapy, we call it as difficult to treat asthma, untreated asthma, or severe therapy resistant asthma, according to WHO. So what are the investigations? As I said, investigations in asthma are of two types. First thing is to rule out alternative diagnosis. Second thing is to know the severity of asthma. What is the severity of bronchoconstriction? What is the severity of inflammation? These are the conditions we look at. And third is to response to treatment. So you have given treatment, you have diagnosed the severity of asthma, you given treatment for a certain period of time, you again recheck about the FEV values, lung capacities, about the inflammatory markers, if they have come down or not. For these conditions, you get investigations done, but you will never get investigations done to diagnose asthma per se, and never for this difficult asthma. So you do a CBC ESR basically to rule out chronic infections in the child. And you do an absolute eosinophil count. According to me, absolute eosinophil count has got no role in diagnosis of asthma. It might only suggest that this patient is suffering from eosinophilia. Eosinophilia can be because of any reason. It need not be allergy always. It not be IgE induced always. So you look at total IgE. Again, every patient with having a higher IgE levels don't need to have asthma, don't need to have all allergies. That is something which we need to take into consideration based on the clinical features of the child. The child has presentations of allergy and the IgE levels are also high, then it becomes quite significant. Then you need to connect it. Then you look at a serum specific IgE, you know, to understand what kind of IgE is the one which is troubling the child. And sometimes very high IgE and the child is not responding to treatment, you give an anti-IgE regimen for the child. Aspergillosis is quite common, especially in urban population and especially in older population, which can mimic asthma, and where itraconazole is a drug of choice which can be given, which has got excellent response. And we look at prednisolone and cortisol levels when the child is given for more than 4 weeks of 4 to 6 weeks of highest dose of corticosteroids. We need to look at prednisolone and cortisol levels because the child might suffer from severe side effects, in order to see for any steroid sparing drugs can be used in this juncture. That is something which we need to look at. So other investigations, such as only if warranted, you're going to do echocardiography to rule out heart conditions, bronchoscopy, obviously to rule out any congenital malformations or foreign bodies, and XL nitric oxide is something which we use to know the controlled regimen, whether the treatment is responsive or not. See, if force-XL nitric oxide, otherwise called as FeNO. Nitric oxide is a substance which is released as an inflammatory marker. Whenever there is an inflammation which happens in an airway, nitric oxide is released. So they measure the amount in particles per minute, ppm. So if the ppm is very high in FeNO, in the initial part of the treatment, you give a treatment for a certain period of time and then check FeNO again. It tells whether your medicines are working or not. That's where you use it. It's not for diagnosis of asthma. It is only to know the treatment. Sleep studies are very important because OSA means sleep disturbances can obviously, obstructive sleep apneas, adenoids, these are all the things, sleep disturbances can trigger more asthma because the child might suffer from more night attacks. If the child is not sleeping peacefully, it might disturb his hormone levels. And obviously the child might develop severe other problems and he'll be having mouth breathing. That's another thing which we need to keep in mind. And sweat chloride test basically to rule out cystic fibrosis. So this is just a paradigm chart. This is quite a busy chart. I'll just explain it. This is what I've explained so far. Whenever you get a case of diagnosed asthma, which is not responding to your regular treatment, obviously rule out alternative diagnosis, rule out comorbid conditions, and then you get into optimize your treatment. You step up your treatment. Give a treatment for a minimum period of 6 weeks and look for response. Don't step it up within 1 week to 2 weeks until unless the child is landing up in ER. If the child doesn't land up in ER, you have given a treatment, wait for at least 6 weeks for the treatment. The child doesn't respond, then optimize the treatment, keep on stepping up till you reach the highest level. And always look at the technique, the compliance, the adherence. This is something which we need to look at. If these 3 things are fine, then only we call it as difficult to treat asthma. So how do you manage? First and foremost, I said environmental control. It's as simple. See, major allergens are dust mite, your cockroach, and your fungal. See, change your bed sheets and pillow covers every 3 days. See that curtains are not used on a regular basis. There's adequate sunlight into the room. There is minimal particles on the bed, and you don't eat on the bed. These are few principles which we tell to the patients most of the time is allergen levels automatically, dust mite allergen levels automatically goes down. And see that the food is restricted to dining table and kitchen, the cockroach allergen automatically goes down. And see that there is adequate sunlight and ventilation in bathrooms and closed areas, automatically the fungal mold will go down. There are few techniques which we can advise and see that if it is possible to shift the house away from the areas where there is severe air pollution, or shift the school. If the child is studying in a school where there's a significant air pollution nearby or traffic signals nearby, we need to see that, child moves to a different area. There's some things which we can do. Paternal smoking or maternal smoking in-house smoking should be strictly avoided, especially where children live in. Pets should not be allowed in bedrooms. If you really like the pets, keep them, restricted to the areas where they don't enter into the bedroom, as I have already commented about air pollution and dust mites. And as far as the treatment is concerned, the guidelines for the severity doesn't exist most of the times. As a matter of fact, whenever the child comes with a near fatal attack or a severe attack, guidelines definitely exist, but there are no significant guidelines, clear international accepted guidelines for the highest point of the step. What you reach the highest step, there are no clear guidelines, because children especially suffer very less, and there are no clear guidelines. It is based on our experience, based on the studies, whatever we get. And most of these studies, unfortunately, whatever we get are adult studies or adolescent studies. And most of these studies are extrapolated from other. Very few studies are present in India as far as severe asthma is concerned. So aim of the treatment should be to obtain the best possible result when there is a failure of optimal control with the least desirable side effects. As far as possible, try to decrease the side effects, even if you are on the highest dose of treatment. And the treatment should be practical, it should be reasonable, it should be viable for the patient. If it is too costly, if it is too cumbersome, the patient doesn't understand the treatment regimen, there is no point in giving it in the first place. Try to balance all these when we decide the treatment for the patient. And initially, whenever the child lands up in this scenario, we always will be having the highest dose of inhaled corticosteroid along with LABA. You keep on increasing the dose of corticosteroid along with LABA. It acts as a very good therapy as far as the controller concerned, because what happens, ICS and LABA can act both as a reliever and a controller certain scenarios. We call it as a smart treatment, and we keep them in a high dose and then watch out. The child doesn't respond, we keep them on oral corticosteroid. We keep that 2 mg per kg initially for 2 weeks. Doesn't respond, we double the dose. And once the child responds after 2 weeks, we start to taper the dose for the child. And once we are tapering the dose, we keep on adding other adjuvants like anti-leukotrienes, some things which can be added as far as the child is concerned. And we continue to give low-dose corticosteroids for a certain period of time. And trial and error is done as far as monitoring and functional parameters of inflammation is concerned. These corticosteroids are tapered 50% every 2 weeks from then on, and gradually they are taken off. They are not taken off all of a sudden. And why the child have a deficient response to oral corticosteroid? Even if you give oral corticosteroid, some children don't respond. It is because of incomplete absorption, maybe due to GIT disorder. The child might be suffering from severe GI malabsorption syndromes, where the child, they will have decreased response to oral corticosteroids. Failure to convert prednisone to prednisolone due to enzymatic alteration, a significant condition will be present, though very rare in children. But this is a condition where your prednisolone won't act. And rapid elimination of the drug due to drug-drug interaction, which can be a possibility, and corticosteroid resistance can be there. How do you confirm a corticosteroid resistance? When you have given a 2 weeks regimen of treatment, the FEV doesn't reduce by more than 15% despite giving a 2 weeks of optimal dose of oral corticosteroid. We call it as a corticosteroid resistant asthma, after even though the child responds to the bronchodilator test. So if there is no response to a treatment after 2 weeks, normally what we do, we double the dose for another 2 weeks. Those responding to the higher doses then are kept on that dose for a certain period of time and then tapered gradually. And some may respond to IM steroids instead of oral steroids. So triamcinolone can be used 40 mg every 10 days, especially for children above 12 years of age. And always use prednisolone in case of a conversion failure instead of getting into methylpred, hydrocortisone, or drugs like that. So if a child has significant amount of IgE, high amount of IgE or allergic asthma, or which is causing a lot of inflammation in the airways, and the child is requiring highest dose of steroid, highest dose of inhaled corticosteroid, not responding to the regular therapy, then we call it as atopic asthma, which is unresponsive. And that is when we prefer omalizumab, which is an anti-IgE antibody. This is something which is giving very good results, but only in certain scenarios. We don't give for every case of unstable asthma. We tend to categorize the children. Previously, it was suggested for about 12 years, and from last 4 to 5 years, it is used for children above 6 years as well. It is based on the weight of the child and also on the IgE level. Just to give an example, it is for the Ig levels which almost cross 1000 to 2000. It is not for Ig levels below 1000, just for the information. And for the conditions where the patient doesn't respond, it is given in a doses of between 150 mg to 375 mg. There will be a dose chart which will be given. On one side, there will be weight of the child. On the other side, there will be Ig levels of the child. Based on that, we need to balance. It is given in aliquot syringes of 75 mg, 150 mg, and 325 mg, 375. It is given subcutaneous route. And you don't give it all the injection at one site, you give it at multiple sites in order for good, adequate response. And you give it over a period of time. Initially, for the first 1 month, you give it, every 2 weeks, 1 to 2 months or 3 months, depends on the response of the child. And then onwards, you slowly taper it out every monthly once for the next 3 months. And then you start, tapering out. And once you got an Ig level and you've started omalizumab, you will not repeat Ig levels frequently because it will take certain amount of time, at least 6 months to 1 year, for the Ig levels to settle down. Only we look at the clinical score of the patient. And omalizumab is never used as a treatment of acute severe asthma. That is something which we need to keep in mind. And if a patient comes with severe asthma with eosinophilic bronchitis, then obviously ICS and LABA is a treatment of choice. OCS trial, oral corticosteroid trial, can be given, and LTRA can be added, montelukast can be added. And then once the trial of OCS given, the patient has responded, we can keep the child on maintenance OCS of a minimum dose of 1 mg per kg based on the sputum eosinophil score. If the sputum eosinophil is more than 20%, 21%, we prefer maintenance oral corticosteroid. If it is less than 21%, we tend to taper it and stop it. Itraconazole can be given for aspergillosis. Oral gold is given as a steroid, sparing drug. Methotrexate as immunosuppressants. They are used as steroid sparing drugs in children who are non-responsive. They are known as eosinophilic bronchitis, but non-responsive to most of the regular treatments. Then we go for steroid sparing drugs. Parental steroids are used only if there is an emergency, or it is used as an IM preference. But normally in pediatrics, we don't prefer most of the times. And if a child comes with severe asthma with non-eosinophilic bronchitis, this has become quite common because in a country like India, non-eosinophilic bronchitis is also quite more common compared to the Western world, because infections are the ones which trigger, especially atypical pneumonias are the ones which trigger a lot of asthma-like symptoms, significant inflammation in airways, where they found out that ICS and LABA in combination works really well. And we need to look out, rule out triggering factors such as smoking, and rule out all atypical pneumonia, causes of all atypical pneumonia. Macrolide is something which is used as a long-term basis. We use it for around 1 to 2 months, and sometimes we use it for 3 months. Clarithromycin has got a good research base, but most of the times it is used above 12 years. We have never used below 12 years as far as the research and studies are concerned, though it is a very good drug which can be given on a long-term basis for non-eosinophilic bronchitis. As of now, children do good response to ICS and LABA as a treatment. If you are in doubt, you can always add macrolide to the child who is unresponsive to your regular treatment. Theophylline, we have never tried in children most of the times, and tumor necrosis factor can be used in neutrophilic asthma, but I've got no experience in it, frankly. And important, what happens is education of the parent. The moment the parent comes to us, educate him about asthma first, educate him about the treatment regimens first, education about the technique, education about maintenance, education when to replace, education when to follow up, education when to seek emergency. These are all the methods, and what to do in emergency. These all things needs to be explained to the patient. A good amount of time to be taken. Normally the method is, the moment the patient is diagnosed with asthma, we tell them to come back after 1 week, then tell them to come after 4 weeks, every 4 weeks for the next 3 months, and then onwards every 3 months based on the response of the patient. That is when the patient will be good, and always tell them to come back with the inhalers and kits, whatever they were using. And there's some licensed therapeutic approaches for these children who are suffering from difficult to treat asthma, such as high-dosed inhaled corticosteroids. You can use a smart therapy where a combination of ICS and LABA can be used both as maintenance therapy, also as a reliever therapy in between. Still, it is in study, it is not proven completely. Anti-IgE treatment, whenever we feel that, in order to decrease the steroid sparing effect, moment you give an anti-IgE treatment, the steroid, side effects of steroids automatically go down by almost, usage of steroids automatically goes down by more than 50% in these children. So other unlicensed treatments such as methotrexate, azathioprine, cyclosporin, subcutaneous terbutaline. There's a lot of research on mepolizumab, which is otherwise anti-IL-5, especially in allergic asthma, which has shown significant promising results. Maybe in future we'll be using it quite commonly. We are not using it right now. They're using it in Western world. Maybe in future we're going to use it. Bronchial thermoplasty is already used in Hyderabad right now. Hyderabad has become a very good center for bronchial thermoplasty, especially for adults who are suffering from severe asthma. What do? They do a radiofrequency albation of the inflammation of the airways. Automatically, the possibility of bronchoconstriction and inflammation reduces by 50% for at least 3 to 5 years once the patient undergoes bronchial thermoplasty. But it is not tried in children so far. So whenever you get a severe case of asthma, you exclude comorbid conditions, you exclude all conditions of difficult asthma. Look at the adherence, look at the inhaler technique, and also look at whether the patient is therapy resistant. Look at all the licensed regimen in this patient, try out those licensed regimen. If that doesn't work, look at the unlicensed regimens, and always rule out differential diagnosis. That is something which we need to keep in mind. So what are the recent advances? Recent advances is you're now going with phenotype-based approach. Like I said, if the patient is more of allergic asthma, they go for IL-4, IL-5, and IL-13. You give an anti-IL-4, anti-IL-5, or anti-IL-13, the patient responds really well. You don't need to give steroids that much for this patient. They respond really well to regimen. And triamcinolone injection if oral corticosteroid doesn't work. And tiotropium is already being introduced in India for children about 12 years right now. It is showing really promising results as an anticholinergic drug. Anti-IL-5 mepolizumab, I have already said, this is something which can use as a phenotype-based medication. And macrolides for neutrophilic asthma, still under research. Maybe in shortly we might use it for children who are not responding to regular regimen and who are diagnosed as neutrophilic asthmas. Anti-TNF can be used as a very good drug for neutrophilic asthmas. And to conclude, difficult to treat asthma requires systemic approach, rule out alternative diagnosis, comorbid conditions, compliance, and improper treatment. Investigate according to the case-based scenario. Asthma is a heterogeneous dynamic disease. You cannot have a fixed regimen. Guidelines only give you a framework. It is you who have to decide what to give, what not to give, what to add, what not to add, and what to subtract. This is something which we need to keep in mind. Identify asthma phenotypes and treat accordingly, whether it is triggered by viral infection, whether it's a multi-trigger wheeze, whether it is, the patient is suffering from allergy, eosinophilic asthma or non-eosinophilic asthma. Based on that phenotype, we can definitely manage. Patient education and frequent monitoring still becomes the cornerstone for treatment of difficult to treat asthma. So to conclude, if you look at this picture, I see a beautiful couple, singing in a garden. But for many people, it might look like one old woman and one old man sitting opposite to each other. So it is in what we see and what we perceive, it is what we manage. So all difficult to treat asthmas are not really difficult. We need to look beyond. History becomes the cornerstone for management of asthma. Thank you.
Yeah, Dr. Suman, wonderful talk. You more or less you covered every aspect of difficult asthma. One doubt, one question from my side.
Sir.
I see some so-called chest practitioners, chest physicians doing a PFT very often and trying to play in the minds of people saying that PFT is important to tell you whether asthma is well controlled or not controlled. As a practitioner, I feel clinical assessment is more important, and clinical assessment of grading like mild, moderate, or mild persistent, or I feel that is important. What's your take on these frequent PFTs?
First thing is PFT cannot be done in children below 5 years. And according to my personal experience, only the child above 8 to 10 years, the child will be very comfortable as far as PFTs are concerned. Second thing, PFT, as I said, is to response to treatment. It is to know how severe is the bronchoconstriction. So that is the inflammatory airways. You have given a controller regimen. After 2 to 3 months, I would recommend initially, when the patient comes to you, you can do it once in 3 months. Absolutely. In order to know after 3 months, whether you need to step up or step down the regimen. For that purpose, you do a PFT. You don't just keep on doing every month in order to know the response of the treatment. If the clinical score of the patient is absolutely fine, the child doesn't have any night attacks, the child is not using any reliever therapy over a period of time for 3 months, why do we need to do a PFT? We don't need to do a PFT. Once in 3 months, because you need to step up or step down, you wanted to know the patient has responded well to the treatment. For a diagnostic purpose, you wanted to do a PFT. That is something which is more than welcome. But otherwise, PFTs, especially in children below 5 to 7 years also, I wouldn't recommend on a repeated basis. But this is the way you are supposed to use PFT as far as PFT is concerned.
Some time back, people used to give injectable immunoglobulins. Maybe it's immunoglobulins were given some time back. Your take on that?
Which immunoglobulin, sir?
Injectable, I mean, whole that.
IVIG?
No, not IVIG. The histoglob, some injection was there.
Absolutely no idea, sir. We have never given not recommended.
Right. Go on. It's wonderful talk. And Dr. Vamsi?
Suman, I have this one. I was hearing a lecture very intently, but I have an objection. I didn't hear about anything about immunotherapy out there in the.
Sir, you are there, that's why I haven't mentioned. So just to push it.
I'm not going to speak on it.
No.
I'm covering only diagnosis.
So according to
I'm only covering diagnosis.
Yeah, very good. So you have got a right point. According to GINA guidelines, if the patient doesn't respond to, is on the last stage of treatment, higher stage of treatment, the patient is not responding, is known to be allergic, and the serum specific IgE levels are quite high. And if that's for that serum specific IgE, immunotherapy is available, it can definitely be used. Thanks for bringing it.
Yes. Because I've been using it in anecdotal episode, this one cases I have where I've used it.
Yeah, thank you, sir. Thank you. Definitely it can be used in these scenarios.
Yeah, it may not sound appropriate. See, like for diabetes, we do this HbA1c. Like that, do you have any test, a parallel test, to say whether asthma is controlled or poorly controlled over the last or the preceding 100 days? Do you have any test like that?
There is no specific test for asthma. It's only, as you rightly said before, so it's a clinical score. There's no specific test for control. As I've said, you do a FeNO to know whether the inflammatory markers are present or not.
Right.
You do a PFT not to know whether the lung capacity FEA has got better or not. It is only response to the treatment. That's it. And based on the clinical score, you don't have any levels, blood levels where you can take up. You can't say that Ig levels have gone down, his asthma is under control. That's something which we cannot use. So definitely not. It's only clinical scores mostly.
Thank you. Thank you very much, Dr. Suman. So our next talk by Dr. Arif Ahmed, our senior allergologist and veteran among immunologists from our city. He is going to talk on diagnostic allergic disease in pediatric practice. Over to Dr. Arif. And Arif, is a senior professor at both the Muslim Maternity and Shadan Medical College, as well as he runs his own exclusive one of the first few allergic centers in the city, and he is involved in immunotherapy, skin testing, as well as a comprehensive allergic care at his chamber. And as you know, Arif is well known across the country as a speaker, as an author of several books. Over to Dr. Arif.
Thank you, Dr. Arjun, for a kind introduction. And I'm sure you must have gone through my book. Anyway, at the onset, I must thank Dr. Narayan Reddy for conducting this wonderful program, and also Dr. Pavan and Dr. RSV Krishna for maintaining the time, because I was just scared that it might extend and then the clinic time will start very soon. So let's get on. So my topic for today is diagnosis of allergies or allergic diseases. So this is the first slide, and if I'm sure most of you all must have watched that beautiful movie, I would say a really beautiful movie called The Dirty Picture. And in that famous dialogue of Vidya Balan to Imran Hashmi, and she says, picture सिर्फ 3 चीजों से चलती है, entertainment, entertainment, or entertainment. And she gives that wink. So, thank you, Dr. Arjun. So in allergology, in allergy, the whole thing depends on the 3 things, that is clinical, clinical, and clinical. And if you are a good clinician or you apply your clinical senses, you do not need any diagnostic test. The whole matter gets solved over there. But there are a few tests which you may need to do, which are to make sure what you have confirmed, what you have thought about in a clinical way. So let's get onto that. So I've been listening to the lectures all throughout in the day, and most of the speakers, almost all the speakers, have covered almost all these things. So I'm sure this has been nothing other than a revision for most of you. Now, the whole spectrum of allergic disorders which we have covered today is what you see on the screen out here, but a few ones which you missed out here were the eye allergies and the drug allergies and anaphylaxis. So, but the rest have been covered, but a few important salient features I will speak regarding those condition which has already been covered and which I have mentioned in my slide, and since it's been covered earlier, I'll just skip through. So the first slide, which I said is clinical, what is the most important thing is a meticulous history taking. So what do you mean by meticulous history taking? So by a good history, I can narrow down the suspected allergen list. Okay, so for that, you need to have a thorough knowledge about each allergen and what are the symptomatology it causes. And then, it's like a police investigation, like a crime investigation. You try to narrow down on the suspected allergen or the suspected criminal, and then afterwards you apply a few tests to only confirm it. Then after that, you can, and that is the specific allergy test. Next thing is a very important thing I want to mention, that positive allergy testing has no correlation with the severity of the allergic state. Okay, now what are the role of the test? Two. One is to support the diagnosis, and the second is to identify the allergens. So now support the diagnosis to confirm A2P. Total eosinophil counts more than 20% of total. Absolute eosinophil count weighs more than 1500, and total Ig elevation more than 4-fold. Now if you all have been listening to Dr. Suman's lecture just now, you'll find that this is not going to help you because of these reasons. There are so many conditions which will have associated increase in eosinophils. Besides the allergic diseases, you have infectious diseases, you have the hematological neoplastic disorders mentioned here, and the endocrine disorders. And then you have these conditions which have very high serum Ig concentrations to the level of 2,000 to 5,000 to almost 10,000-20,000, such as AB, allergic bronchopulmonary mycosis, allergic fungal sinusitis, atopic dermatitis, hyper-Ig syndrome, Ig myeloma, Kimura's disease, Netherton syndrome, systemic parasitosis, and tuberculosis. But besides this, there will be other conditions with specific organ involvement and immunological reactions, which will have high IgE, we mentioned here on the screen. And in addition to this, there are the non-allergic diseases, which will have altered Ig levels, where the total serum Ig levels will be altered. And you have the whole list of parasitic diseases, not to miss any of the parasites which are existent, including the last one, that is malaria. Then you have the cutaneous diseases, which will have increased IgE. You have the neoplastic diseases, okay? And then there are other diseases like I think nothing is spared, including cigarette smoking and alcoholism, which will all lead to increase in IgE. Then you have the immune deficiency diseases, which I mentioned earlier, and certain drugs. So basically, your high Ig level is not going to, and neither is the eosinophil level going to help you to diagnose allergy. In fact, as far as allergy is concerned, in 40% of the proved allergy cases, the Ig level may be 30 to 40%. The Ig level may be normal, absolutely. So it is more misleading than leading you anywhere. So what do you do next? What is left with you? So we have tests to confirm local allergy, that the nasal eosinophils more than 5 per field, because nasal eosinophils correlate well with the bronchial eosinophils, and they are both increased in increase in asthma. And this is one of the study I have going on with one of my PGs in Shahdan Medical College. Then there is the other one, is to confirm evidence of inflammation, the Brett nitric oxide test, which Dr. Ashfaq as well as Dr. Suman have mentioned. It is mentioned here in higher centers, but it is done routinely in my clinic now. We are not doing nitric tests because of this COVID thing, and also all this lung function tests and nitric oxide tests has been put on a hold because of COVID. Now, to diagnose anaphylaxis, get my point very straight. The way to diagnose anaphylaxis is strictly clinical, but there are in certain situations where you might need to do a serum tryptase level, and the tryptase level will only be elevated if the entry is through a parenteral route, such as an injection or an insect bite. And the sample should be collected within 4 hours. Now, I'll give you an example which we had. We had a 9-year-old female who became pale and bradycardic when given IV ceftriaxone. Patient recovered immediately with bag and mask and oxygen. Since parents were very agitated and blamed us for giving ceftriaxone, patient was admitted, developed a similar episodes on cannula insertion in the hospital. And therefore, we were very sure, and by now, everybody is very sure what the diagnosis is. But to remove the doubts in the parents' mind and the need for future medication of ceftriaxone in this particular patient with the tryptase level, it costed 7,000 rupees, okay, and it came normal. Therefore, after severe allergic reaction without a known cause, to identify the trigger, okay, now we have to make sure that you can do serum tryptase level because it does have medical legal value. Now, the tests which are available are the skin prick test, which is the widely prevalent one, and the intradermal test, which is done when you are very sure of there being an allergy and the skin prick test is negative. Then you would want to do an intradermal test. Nowadays, nobody does intradermal test because of the risk of anaphylaxis. Then you have the patch test. It is more done by the dermatologist. It's not a common test in children. It is done in cases of contact dermatitis. You have the nasal allergen test. It is not a test done routinely in practice. Oral food challenge test is being covered. Then we have the drug provocation test. Yes, the drug provocation test is a very important test because the problem with drug allergies is that the blood tests are not validated and the skin prick test is limited to very few tests. So what you need to do is the drug provocation test. For that, you need to admit the patient to a hospital. And if you want to know more about this drug provocation test, you can go through my chapter on drug allergy on the book of IAP textbook of allergy, which has been brought about by Dr. Sukumaran and Dr. Jose. And the last and the most important thing is the laboratory test, which we'll go through. So now what are the hurdles of testing in allergy, especially the skin prick testing and all? So one, it may be patient related. The problem with patient related is that if the patient is very young, non-cooperative, we cannot do a skin prick test, or if the patient is on antihistaminics and you cannot stop it, you cannot do it. Then it's physician related. Most of the time it is physician related because we do not know that, most of us do not know the technique of doing the skin prick test or a bit apprehensive about doing it. So that's why we are not doing it. Or it could be both. And neither is when, yes, I have a patient, I can do the skin prick test, the patient is willing, but I won't do it because I know this is peanut allergy. Now, what I want to do, I would prefer doing to know the severity of that peanut allergy, and I would like to do the component resolved diagnosis, which is a topic for another day. Now, many of the laboratories and all will tell you this about the blood test, that it is a predictive biomarker of severity of symptoms. Neither the blood test nor the skin prick test is a predictive biomarker of the severity of symptoms. They're predictive of immunotherapy responders. Neither the blood test nor the skin prick test has any predictive value for immunotherapy responders. And the last one is predictor of tolerance to food allergens in children. Yes, it is a predictor of tolerance to food allergens. That is the component resolved diagnosis, or where you are assessing the different components in a particular food. Now, this is the test. Now, what is the test for specific IgE? One is this RAS test. Now, this RAS test is everybody knows what is RAS test, but as far as specific IgE is concerned, RAS test is now, since 2000 test, is an outdated test. You should never do it because you get a lot of false positive, and rather than leading the patient anyway, you're more misleading the patient. And you have a lot of laboratories which are doing this RAS test and misleading patients. And you see this very often in the newspapers and all, exposed with fake test results rated, health department based diagnostic centers. I mean, they give you this 200 tests and all with almost at a cost of 3,500 rupees. Is one of the most unreliable things, or the most unreliable method that it is being done with. And therefore, you have to be very clear by which method you are getting it done and where you are getting it done. And the method is now what you call the immunocap. Okay, the immunocap method. Sorry. Okay. Okay, it's an enzyme link, the immunoassay, and this is the method. Now, Thermo Fisher has branded this as immunocap in other, and that is the only one which is available in India, as far as I know. In Germany, they have a different one. In USA, they have different ones. But what we have in India is the immunocap. So we have the allergy screening. For the screening now, this Thermo Fisher Labs has brought about with this FADIA-TOP, which is a screening test, okay, for infants and for adults. Now, where they accumulate a few very common allergens and they use it as a screening test. Now, I want to give a very clear clarification on this. I, as an allergist, would never ever do this FADIA-TOP test because I rely on a good history and a good examination. I give time to the patient, and by this, I can find out whether the patient is atopic or not atopic. But if there's a busy practitioner and if he cannot come take a good history or a good history, or he doesn't have the time, a substitute for that time and lack of knowledge, this FADIA-TOP can be used, where if it is positive, then it may suggest, yes, this child is atopic and you need to look further in this child for the specific allergen. So the whole range which is available now for allergy screening is the immunocap. We have this specific IgE which is done, and we have the allergen components, which is not at the moment not available in our country. So now let us see some problems with this blood test. So this patient which you see in front, allergic rhinitis with severe eczema or with asthma and with food allergy. Now this girl is around 11 years. She done her serum FEI, the normal value is less than 0.10. Now almost everything is raised out here, okay? But you have to, when you want to look at these results, you should look first at the total IgE. It is more than 30,000. Normal is less than 64. So if the total IgE is raised, definitely your specific IgE will also be raised. So how would you interpret these results? If the specific IgE is more than 100, yes, you can safely say yes, the allergy is a high possibility in this particular case. While the other food items where the specific IgE is raised, okay, but if the child is eating those particular food items and without any clinical reaction, then you can safely continue the food in that particular item. So the point to be taken out here is that you interpret the specific IgE in lieu of the total IgE. Okay, that is a very important message out here. So this patient had egg white of 39.70 and was allergic, while all these food items which were there out here, which were quite high, including wheat and gluten, the patient was consuming these food items freely without any problems. So now how do you do the skin prick test? These are the different steps of doing the skin prick test. So to make it a very simple one, you have to just clean the part, you have to draw the circles, and I'll give you a practical demonstration of this on the screen. Okay, what you do is you make a circle out here as I made on my hand. You take a drop of the allergen, okay, and you put the drop of the allergen on. I hope you can see it. Yeah. You can see, oh, here you put the drop of allergen, and then you take this lancet with you, hold the lancet, and you just prick it, okay? I hope everybody can see it. And you just prick it out here, just lift it very lightly. Make sure there is no blood over there. No blood comes. Because if your blood comes, then you may get false positive. Wait for 20 minutes, and after 20 minutes, if you get a reaction, yes, more than 3 millimeters, then it is positive, and you have to correlate it clinically. So for very young children, if there's a problem in doing it, you can show their favorite videos, tell them stories, try to make them play there on the cell phones, or try to, if they're very religious minded, try to recite some religious mantra, whichever they may be knowing, and that might help to just using some diversionary tactics. But there's another one which is we use for food, is known as the prick-to-prick test. Patient comes to me, he says, I have banana allergy. Okay, all I do is or he has apple allergy. You just pick the banana, you prick the banana or the apple, and then you prick the skin and wait for 20 minutes. If there's a reaction more than 5 to 8 millimeters, yes, he has banana allergy. or he may be having that particular food allergy. This is done for fruits or vegetables. Okay, but also at the same time, you should have a saline control and a histamine control. But this can only be done if the patient is off antihistaminic for at least the last 7 days. So if you compare the two, the skin prick test and the blood test. So the skin prick test, yes, it'll give you immediate results, clear demonstration of to patients of the allergies, better sensitivity and specificity, because the blood test has not been validated for food allergies. No interference from high total IgE, as you saw in that particular patient, recommended as a diagnostic test of choice by various authorities. Okay, but the other problems is it requires equipment, reagents, and trained staff. I mean, not everybody can do. You have to have that clinical skill to do it. You have to know how to interpret it. It requires patient cooperation, although it can be achieved and by using a lot of coaxing and training. It requires areas of normal skin for testing. Yes, skin prick test requires it, which is not so for blood test. And you have to stop the antihistaminics and some antidepressants and other drugs for several days before, at least 7 days before the test, which is not so for IgE testing. Now, what has not been covered today is VKC, vernal keratoconjunctivitis. And this is a paper of mine which has evaluation of aeroallergens in vernal keratoconjunctivitis being presented in YAKI this year in 2021. And what were the conclusions of our studies was the symptoms were the same of aeroallergen positive as well as aeroallergen negative in VKC patients. So whether the patient has, we had this patient, 100 patients in which we of vernal keratoconjunctivitis, which is a very common thing in children, but we don't see it because most of the time they are going to the ophthalmologist, to the eye specialist. They refer to me and I do the testing. So whether, even if these the symptoms are the same, whether it is positive or negative, but there's a very important thing, that as the comorbid conditions increase, okay, in such as allergic rhinitis or an asthma, there's a statistical significant increase in the positivity of the aeroallergen in VKC children. And the most common aeroallergen which we have identified is dust mites in children with vernal keratoconjunctivitis. Food allergy, yes, has been covered by Dr. Narayan Reddy. And the problem is that 20% of the individuals in the population believe they have an adverse reaction to food. And all these reactions, food allergies, these reactions are not immune mediated. And the other important thing is, and the other very common thing is in your practice, you see patients coming and saying that I have this banana allergy. And I've explained earlier with this how banana causes an irritation, a reaction in the throat. So I will not go through it now. But for such patients, you can do a skin prick test or a direct prick to prick test there and there in your clinic and show to him that there is no banana allergy. So the whole range of tests available for food allergy is the blood test for specific IgE, but most of it is not been validated. The skin prick test, yes, but there are certain limitations. The other very important thing is a food allergy diary. And if you have a well-maintained food allergy diary, you can almost pinpoint the particular food item. Oral challenge test is the gold standard for diagnosing food allergy. Role of IgG test in the diagnosis of food allergy, whatever some lab people might come and tell you, they have no value in the diagnosis of food allergies. So now when it comes to skin prick test, clinical relevance, as far as clinical, there should be a consistent allergen. It cannot be that at one time the patient gets the symptoms and another time will not get the symptoms. He has always to get that symptoms. The negative predictive value is more than 95%. So if the patient with food allergy comes positive, comes negative, you can safely tell him that you can eat that particular % chance that he is allergic to that particular food item, and he will have to go for an oral challenge test. But if there's a large SPT, more than 8 millimeters for certain foods such as milk, peanut, and eggs, you can safely say, yes, you have this particular, you have allergy to that particular food item. Now, the other important thing is normal subjects will also show reaction to foods consumed on a regular basis. Be as South Indians, okay, eat rice on a regular basis. So if you do a skin prick test on South Indians, they might get rice positive 1 or 2, a maximum 3 millimeters. Doesn't mean that they are allergic to rice. But the other important thing is the positive skin prick test and no clinical allergy has a predictive value of developing future allergies. Now, in urticaria, the test, you need to do the testing only in acute urticaria. In chronic urticaria, doing blood test or skin prick test has no value. All you're going to get is false positive values. These are the different tests for urticaria, which has been well covered by Dr. Surendranath. I would get into it. For eczema, yes, you do it to find the allergen aggravating the condition. When we do the test, we say peanut come positive. Peanut is not the cause of eczema. Peanut will be only aggravating the eczema. Triggers for allergic rhinitis, this Dr. Parmesh covered in his lecture. On the left side, you have the aerobiologicals, and on the right side, you have the irritants. You should check for the aerobiologicals and not for the irritants. If you have any lab which is checking for the irritants, just throw that lab report into the garbage. That's what it is meant for. You cannot do blood test or a skin prick test for any irritants. It is strictly for living items, and that is for aerobiologicals. This is a study which was the prevalence of aeroallergens in allergic rhinitis and asthma children in the South Indian city. And this is being presented at Yaki in 2021. And what we showed was that the most common aeroallergens present were the dust mites. But what was unique about our study was that blumia is a very common allergen, dust mite blumia, that is a very common allergen in our city, in our region. And therefore, because many of the labs now, Thermo Fisher is checking for blumia, but earlier they were not checking. So blumia is a very important dust mite which has to be looked for in patients with allergies, with dust mite allergy. The other thing is now, this slide is very important because Dr. Suman mentioned about difficult to control asthma. Yes, you have to look for comorbid conditions. And if a comorbid condition, one of the most common comorbid condition is allergic rhinitis and adenoids. This was a study which was presented in San Francisco and published in the Annals of Allergy. Now, where we showed that with increasing size, with increasing severity of adenoid hypertrophy, there was an increased incidence of dust mite positivity. So when you have these children coming with severe adenoid hypertrophy or difficult to control asthma with underlying allergic rhinitis, specifically look for dust mites. All the three types of dust mites, terinosis, blumia, and farinae, and almost most of the time it will turn out positive. And when it turns out positive, now you have a definite treatment. You have a specific treatment in terms of environmental control and immunotherapy. So this is a very important thing to look for looking for dust mites in cases of moderate to severe adenoid hypertrophy. So in summary, I would reiterate what I said at the very beginning of my lecture, that history is the single most important component in the diagnosis of allergy. The non-laboratory tests, that is the skin prick test, which we do, are cheaper, easier, and more reliable. That is provided the personnel is trained. Okay, if you're not trained, then there's nothing much can be done about it. I mean, we are there to help you out. Okay, and you can send any patient at any time, and we'll be more than happy. Laboratory tests, yes, they're easy to order, but you really need to have a good understanding how to interpret it, because without a detailed study of the patient and without a background knowledge, like some of the things which I have mentioned to you with that case scenario, the allergy blood test may be more misleading rather than leading you to any particular line of treatment or diagnosis. So with this, I would like at the end also mention about my book, Winning Over Allergies. All which I've talked to you is mentioned in this book. Okay, and it covers almost every aspect of allergy. It's very easy to read and it's recommended for both doctors as well as for patients. these words, I thank you. And this is my website, www.allergy.com. If you need more information on allergy, you can always access this website. Thank you, one, and thank you all. And over to you, Dr. Arjun.
Arjun sir, are you there? Vamshi, Dr. Vamshi. Right, so we've come to the last talk of today, and
okay. इसको बोला ना.
all right. So we're at the last talk of today, and what we'll just give me a second. Right. So good evening, everyone. And at the last talk of today, the prevention of allergy in the Allergy CME, my regards to Dr. Narayan Reddy sir, and I introduce myself as an alumni of Deccan College of Medical Sciences, and it's a privilege and a pleasure to be here as a UNICEF consultant and also Secretary of Indian Academy of Pediatrics Twin Cities branch. Being a part of Deccan Medical College and now coming back is like going back to alma mater, and wish there was no COVID and I would have been back in the same auditorium, this time on the podium side and talking about this topic. And it's a little different because I'm probably the only generalist here. Everybody else before me are all qualified specialists in the field of allergy. And it was a little strange for me to be asked to talk about a topic in an allergy specialty CME. And then I realized probably I represent the majority of the pediatricians who are all listening to this. And working for UNICEF, I've realized that this topic for prevention of allergy is probably rightly suited. And this takes me to the modes of prevention. And I'll try to keep my talk very brief, very specific. So if you look at the modes of prevention, this takes us back to the public health days. You've got primordial prevention, which targets the social and economic policies. You have primary prevention, which targets the risk factors leading to injury, disease. You've got secondary prevention that prevents injury or disease once an exposure to risk factor occurs. And tertiary prevention, which is related to rehabilitating people with injury or disease. So 4 different levels of prevention, and it's a very tough task for me to cater to all the levels. And over the time, I have realized that much part of this prevention is also there in the diagnosis and the cure. Now, prevention, most of the time in the West, has become to be a mainstay of management. We know management includes prevention, treatment, management of complications. And prevention is probably the most important. And it's high time every person who seems to be allergic needs to ensure that he has the right preventive treatment that needs to be given. And as I make my slide, it's always very tough because as part of decision making, I'm in doubt because there are so many consensus recommendations, guidelines, so many associations. And this talk actually gave me a chance to look up all of them, right from World Allergy to European, UK, Indian, adult, pediatric. And what do you do when you are in doubt? The best way is to look at evidence and look at what evidence says. And that's probably the way I'll be able to match the specialists, being a generalist myself. So looking at now the evidence, what does evidence tell us on prevention of allergy? First of all, the concept has dramatically changed, and there's a paradigm shift in the concept of allergy prevention from allergen avoidance to development of tolerance. It's not as if you want to prevent allergy, you just stay away from it. That's not going to be the end, be all and end all. Secondly, you can avoid allergen. It is obviously logical, but it's not feasible. It's a multifaceted, complex, and a multifactorial, comprehensive problem, and it definitely needs solution in that regard. And you need general efforts for all the people in the population and specific targeted efforts towards the high risk. This needs to be the strategy, and I'll take you through some of these important factors. So prevention of allergy, if you look at the primary prevention, there are different steps. The first one is the avoidance of allergen or pollutant exposure. This refers to both ingested and inhaled. Second, a very, very strong unequivocal breastfeeding. Third is a hypoallergenic infant formula feed. Next is timely introduction of complementary feeding and dietary modification of pregnant women and infants. So these are various components of primary prevention. I'll quickly, over 10 minutes, take you through what is in these guidelines. And it is very nice that just a month back, 12th March 2021, we have this EAACI guideline, which has written about the prevention of developing food allergy in infants and young children. This is the 2020 update. And let me take you through what this evidence is telling us. So they've done a detailed analysis, looked at a lot of RCTs, and the results are that all of the recommendations about preventing food allergy relate to infants up to 1 year and young children up to 5 years, regardless of the risk of allergy. And there was insufficient evidence in the other age groups. So the task force suggests avoiding the use of regular cow's milk formula as a supplementary feed for breastfeeding infants in the first weeks of life. It also suggests introducing a well-cooked but not raw or uncooked pasteurized egg in the infant diet as part of the complementary feeding. In populations where there's a high prevalence of peanut allergy, the task force has suggested introducing peanuts in an age-appropriate form as part of the complementary feeding. And according to studies, it appears that the most effective age to introduce egg and peanut is from 6 months of life. The task force is against the following for preventing food allergy. That is, avoiding dietary food allergens during pregnancy or breastfeeding, using a soy protein formula in the first 6 months with a wrong notion that it prevents food allergy later. And there is no recommendation for or against the use of 1. Vitamin supplements, fish oil, prebiotics, probiotics or symbiotics in pregnancy, breastfeeding or in infancy. There is no evidence and strongly against altering the duration of exclusive breastfeeding and hydrolyzed infant formulas. No evidence much for a regular cow's milk based infant formula after a few weeks of age or the use of emollients. So this comprehensively covers all the data, all the update across all the manifestations of food allergy. The conclusions from the guidelines are, it's a long guideline, and the update from the 2014 guideline includes suggesting the introduction of peanut and well-cooked egg as part of complementary feeding, avoiding supplementation with regular cow's milk formula in the first few weeks of life. So it is strongly putting forward very well-known evidence-based measures. Now, what is the allergen exposure and how do you prevent it during pregnancy and lactation? See, the role of avoidance of a specific food item is not well established, and we have a recent Cochrane review that suggests that there are 4 RCTs that suggest avoiding a food allergen during pregnancy does not have any protective effect on the incidence of atopic dermatitis during the first 18 months of life. So this common notion of trying to limit the food or the nutrition of lactating mothers, especially in the first few days after birth, has no strong evidence based. Next, the same Cochrane review also suggests that maternal allergen avoidance during lactation also does not have any protective effect on the incidence of atopic dermatitis, and rigorous dietary restriction may actually adversely affect both the mother and the fetus. Some studies, however, are there which depict the stringent environmental control measures with reduction in exposure to house dust mites in early life may lead to less frequent respiratory symptoms in the first year of life. But you need long-term effect on the sensitization on prevention of atopic diseases with more data to stand it. The next evidence is on the AAI, the Adverse Reaction to Foods Committee report, and this is primary prevention of allergic disease through nutritional interventions. And what are the guidelines for healthcare professionals? The strong recommendation is maternal avoidance of highly allergenic foods during pregnancy and lactation is not recommended. No evidence for it, and it need not be done. There are a few highly allergenic foods, but no clear recommendation to avoid them. Next, consult an immunologist or an allergist for the development of a personalized plan for complementary food introduction for any of these scenarios. So as I started, most of the time the general pediatrician is probably enough for us to deal with most of the allergies. And when do you really consult the allergologist? When an infant has moderate to severe atopic dermatitis despite optimal management, infant has immediate allergic reaction to a food which puts them at higher risk for other food allergies. They have a sibling with peanut allergy. Although peanut could be introduced with low risk at home, sometimes you may need to just consult an allergist. And either an infant with positive serologic food specific serum IgE testing to a food not yet introduced, or an infant with undetectable food specific IgE serum testing despite convincing theory of an allergic reaction. The last evidence is from the Journal of Allergy and Clinical Immunology, again released just 2 months back, and this has a consensus approach to primary prevention of food allergy through nutrition, and this has the guidance from all the different bodies which are across the world working on allergy and immunology. The dermatological conditions, and then they note that currently there is no consensus on what qualifies an infant to be at high risk for food allergies, and recent guidance recommends that clinicians consider eczema as a clinical characteristic predictive of food allergy in infants. And based on the available evidence, the guidance committee also suggests that an increased risk of food allergy exists in infants if they meet the following criteria, that is mild to moderate eczema, family history of atopy in either or both parents, or one known food allergy. Next, dermatological conditions and after dermatological conditions, what is the recommendation on delay in introducing potentially allergenic foods? Subsequent recommendation, they say there is no deliberate delay and there is no need to do it intentionally, even including soy, wheat, sesame. What about diet diversity? Once complementary foods have been introduced into an infant's diet at 6 months, the guideline notes that the infant should be fed a diverse diet as a means of preventing food allergy. There is no evidence from RCTs to support this weak recommendation, but the guideline committee points to observational studies that a diverse range of dietary choices could be helpful for preventing food allergy in infants. The last couple of recommendations are on hydrolyzed formula. This guideline strongly recommends against routinely prescribing or recommending the use of a hydrolyzed formula for preventing of food allergy for the development of food sensitization. And this was made because of lack of available evidence supporting the use of hydrolyzed formula. Maternal recommendations, they continue to stay. No reason to exclude anything during pregnancy or lactation. And introducing allergenic foods is the same. You do it at 6 months and ensure that you take the due care in case of nuts. The last few words about asthma before I finish. Cannot escape this entity when you're talking about prevention. And the new updated 2020 guidelines on GINA for prevention of both allergy and asthma. Key points include development and persistence of asthma driven by a gene environment interaction, and for children, a window of opportunity to prevent asthma exists in utero and also in early life, but then the studies are limited. So with regards to allergen avoidance strategies aimed at preventing asthma, strategies directed at a single allergen have not been effective in reducing the incidence of asthma. Multifaceted strategies may be effective, but the essential components have not yet been identified. So the current recommendations for preventing asthma in children are based on high quality evidence, and these will include: number one, avoid exposure to environmental tobacco smoke during pregnancy and the first 1 year of life. So if you have a father at home who's smoking, you are putting your son at risk for asthma later in life. Encourage vaginal delivery. Advise breastfeeding, not just for asthma prevention, but for its numerous benefits. And the last one, where possible, avoid the use of paracetamol and broad spectrum antibiotics during the first year of life irrationally. So that finishes all the evidence that I have. And before I finish, would like you to just look at this person and then recall if you have seen him somewhere. So this person is the one who I would say has laid the base for this entire talk, and how you actually finish with this talk whenever you talk about any disease in general. So this is Erasmus. The phrase prevention is better than cure is often attributed to this Dutch philosopher Erasmus. And now prevention is a fundamental principle of modern healthcare, and it's inherent within the health and social care strategies across most of the countries. As Erasmus says, prevention is always better than cure. Thank you, IAP, TCB, PATS, and Deccan Medical College for the opportunity. It's a proud privilege to be coming back on a virtual stage and talking about prevention of allergies. Thank you. Yeah, so I've just changed the settings. May I now request Surendranath sir, Arjun sir, Pavan, if you're around to give your closing remarks.
Yeah, RSV.
Yes,
Hello?
yes. So that finishes the sessions, Pavan. And let me thank
Great,
Pavan as
great.
well for ensuring that we make this happen. And it's always a pleasure. We've learned pediatrics together as postgraduates, and now it's a pleasure for us to work for IAP together as well. Thank you, Pavan. I hand it over to you to close the session with the vote of thanks as planned.
Yeah, I think Narayan Reddy sir or there, no, Surendranath sir, Arjun sir, please give your concluding remarks before we close down.
So I thank my bottom of heart. It's a memorable CME from morning 9 a.m. to evening 5:30, almost in time to finish. All very excellent lectures and excellent topics. The good knowledge, I think, is all is need of the hour. All pediatricians they cherish this knowledge. I thank IAP TCB Arjun sir and RSC Sri Krishna Vamshi, PATS Surendranath sir and Pavan and EB member Dr. Yashwant and speaker, national speaker, Nagaraj sir, excellently spoken, Nal Sukumaran, Jose sir, Parmesh sir, or principal, Asfaq sir, principal, he spoke very well. So it is excellent and the enriching subject knowledge, everybody, and also our Masuman, Arif sir spoke very well, Jose sir spoke very well, and RSV also spoke very well, prevention, and Chinwat Jakka. So all spoke very well. I think excellent session. I think memorable lecture. I think it is a need. I thank my bottom of heart all speakers, all PATS and Twin City AB members. Thank you, sir. Word to Surendranath. Surendra.
Surendranath sir, yeah.
Yeah, good evening and congratulations. Excellent program. On the dot, we could finish. We have started on the dot, and all the speakers were excellent. I mean, good deliberations happened. In fact, points are known, and topics were excellent. In fact, I thank all the Central IAP Allergy Chapter office bearers, Dr. Sukumaran, Dr. Jose, Dr. Nagaraj sir, and Dr. Parmesh sir, giving their valuable time for today's CME, and especially the Deccan Medical College people who have hosted today's CME with the help of Dr. Srinarayan Reddy and Asfaq Hassan sir for taking initiative for an excellent allergy CME on behalf of Twin Cities branch and PATS. And I thank our vice presidents, Dr. Ravi Kumar and TCB President Dr. Arjun, Dr. Sri Krishna RSV and Vamshi, and our secretary Dr. Pavan and PV Srinivas Rao, who were there for some time. And I thank one and all for a good CME. We could learn so many things. Thank you very much.
So everyone is giving 5-star rating to us. For
What's
the conference.
Naren sir.
Yeah, Joe sir.
Naren sir. Yeah. Naren sir and Surendraji, Pavan and all the IAP, Telangana and all the Hyderabad team and Dr. Arif and all. This is a wonderful event today. On the behalf of Allergy chapter, I congratulate Naren Reddy sir for a wonderful arranging a one-day total allergy CME. I think this was a enlightening all the general pediatricians, all the allergy specialists having in-depth knowledge in all the aspects of allergies, especially all the leaders of the IAP allergy chapter done a wonderful job. Hearty congratulations to Naranji, Surendraji, and all the Pavan secretary and all the IAP team done a wonderful job. On the behalf of allergy chapter, I extend thanks to all of you conducting a allergy chapter in a national one-day excellent CME program. All the faculties have done their justice to the participants in an excellent job. And thank you all. Thank you, sir.
Dr. Arjun sir. Arjun sir. Arjun is there?
Layer sir, yeah, I don't think he's around. You can just ask the other faculty to speak and maybe one or two participants as well.
Pavan and yourself get talk now. Anybody is there in my group faculty? National
No,
faculty?
sir. I think that's all. So if we have acknowledged the presence of everyone from IAP, even from Deccan Medical College.
Yeah, RSV, final announcement from you regarding that certificate and all. I think you
said
that you are
that's,
going to
that's neat of them. That's important.
I'll do that. Sir, Naren Reddy sir, anyone from Deccan? Altaf or principal, anyone around?
Altaf is there, Habib is there. Just check it. Dr. Habib and Altaf. Sri Lakshmi.
None of them are there, but I think I'll convey regards on behalf of my alumni to all of you. So I think we have heard from everyone. Arif sir, you have anything to say before I close?
Arif sir.
Oh yeah, Naren, that's a great thing that you organized. There's no doubt about it. And maintenance of time, that is a fantastic.
Yeah.
So clinic, I'm ready for the clinic.
Thank you everyone. It was very tough when I was telling Naren Reddy sir, I'm going to tell what each one should do, when to come, what to do. He said, do it. As long as the end result is good, it doesn't matter. So thank you all the faculty for understanding and cooperating. It's been very smooth. We didn't have any technical glitches trying to run around speakers or testing things. Thank you everyone. So before I hand it over to Pavan to close, announcement for all the participants, and you have already shared your email IDs in the Google registration form. What we'll be doing is we'll be taking that up and give us a day or two, probably by Monday. We'll try to get a personally written certificate for each of you who have already registered. And for everyone who has registered, Naren Reddy sir has agreed to ensure that the certificate reaches everyone who has registered. Am I right, sir?
Yes, sir, right.
Yeah, so we'll be sending across by email the certificate with 4 Telangana State Medical Council registration points to the faculty as well as to delegates, everyone who has registered. And this will have the signatures of the medical counselors. Thank you. Over to you, Pavan, to close. If we have your treasurer, PV Srinivas.
PV Srinivas Rao, sir, are you around? I'm not sure, sir, is there.
Arjun sir is left.
Sir,
yes, sir, Arjun sir is also there. Yeah.
I think, Pavan, you can close the session.
Close.
Final vote of thanks and close.
Right. On behalf of Pediatric Academy of Telangana State, it's really indeed a privilege for me to propose vote of thanks. I thank all the man behind this entire workshop, Dr. U. Narayan Reddy sir, who has initiated the process and which is supported by our teacher, beloved teacher, Dr. Major Nagaraju sir, the father of pediatric allergist in India, and followed by my president, Dr. Surendranath sir, and Dr. Arjun sir from IAP TCB, and Dr. RSV Sri Krishna from IAP TCB secretary, I think, and the principal of Deccan Medical College, Dr. Ashfaq Hussain sir, and all the speakers, all the national speakers, H. Paramesh sir, Joe sir, Arif Ahmed sir, and all the esteemed speakers, Srinivas Jakka, Surendranath sir, everybody did a fantastic job. I think I thank each one of you, and above all the delegates who have enthusiastically, within a one day, I think there is a whooping registrations of more than 700. And the attendance was also throughout very good. At the end, we are seeing almost 90 till the end. They are there. That shows the importance of the allergy raising, and this is very important subject. I think you all learned about that. Certificates we are going to ensure that each one who have registered will get through email. So with all that, I thank the organizers from Deccan Medical College and IAP TCB for coordinating so nicely and conducting this fantastic, wonderful, successful program. Thank you so much. You can all leave now.
Thanks everyone. Ending the meeting now.
Yeah, thank you.